Acne is one of the most common disorders treated by dermatologists and other healthcare providers, with more than 90% of the world's population being affected by acne at some point of their life. Acne vulgaris, or simply acne, is a common disorder affecting the sebaceous follicles with several factors that influence its development. Since its treatment would require antibacterial action, antibiotic resistance is an issue to consider. In dealing with acne vulgaris and other bacterial infections such as impetigo, carbuncles, and furuncles, entrust your patient's skin to effective treatment with less worries about resistance with Nadixa. Nadixa is nadifloxacin, the first topical quinolone indicated for acne vulgaris and bacterial skin infections. It has a broad-spectrum antimicrobial activity that works mainly by inhibiting DNA gyrase, which then prevents bacterial activity and causes cell death. With this mechanism of action, there is a very low resistance compared to macrolides and lincosamides. It also inhibits the production of pro-inflammatory cytokines and suppresses androgen reception transcription activity to 29.8%, giving it anti-inflammatory and anti-androgenic activity on top of its antibacterial activity. Nadifloxacin has been proven to be effective compared to placebo in several studies and was shown to have similar efficacy to erythromycin in reducing acne lesions with no resistance generation in 12 weeks. When used in combination with adapalene, nadifloxacin showed a higher and earlier reduction in inflammatory lesions. It also showed significantly less erythema and less proportion of dryness compared with adapalene monotherapy. In terms of safety, the general tolerance of topical nadifloxacin treatment was rated good or very good by 98% of investigators and 96.6% of patients. In combinations, nadifloxacin does not lead to substantial reactions versus drugs alone. Nadixa is available in 10 mg per gram 1% aqueous cream solution. Nadixa offers strong broad-spectrum antimicrobial activity, low resistance rate, additional anti-inflammatory and anti-androgenic effects, overall efficacy in monotherapy, and in combination with other anti-acne agents, an excellent tolerability profile. Cross out bacteria with Nadixa. New antibiotic treatment for acne vulgaris and skin bacterial infections. Acne is one of the most common disorders treated by dermatologists and other healthcare providers, with more than 90% of the world's population being affected by acne at some point of their life. Acne vulgaris, or simply acne, is a common disorder affecting the sebaceous follicles with several factors that influence its development. Since its treatment would require antibacterial action, antibiotic resistance is an issue to consider. In dealing with acne vulgaris and other bacterial infections such as impetigo, carbuncles, and furuncles, entrust your patient's skin to effective treatment with less worries about resistance with Nadixa. Nadixa is nadifloxacin, the first topical quinolone indicated for acne vulgaris and bacterial skin infections. It has a broad-spectrum antimicrobial activity that works mainly by inhibiting DNA gyrase, which then prevents bacterial activity and causes cell death. With this mechanism of action, there is a very low resistance compared to macrolides and lincosamides. It also inhibits the production of pro-inflammatory cytokines and suppresses androgen reception transcription activity to 29.8%, giving it anti-inflammatory and anti-androgenic activity on top of its antibacterial activity. Nadifloxacin has been proven to be effective compared to placebo in several studies and was shown to have similar efficacy to erythromycin in reducing acne lesions with no resistance generation in 12 weeks. When used in combination with adapalene, nadifloxacin showed a higher and earlier reduction in inflammatory lesions. It also showed significantly less erythema and less proportion of dryness compared with adapalene monotherapy. In terms of safety, the general tolerance of topical nadifloxacin treatment was rated good or very good by 98% of investigators and 96.6% of patients. In combinations, nadifloxacin does not lead to substantial reactions versus drugs alone. Nadixa is available in 10 mg per gram 1% aqueous cream solution. Nadixa offers strong broad-spectrum antimicrobial activity, low resistance rate, additional anti-inflammatory and anti-androgenic effects, overall efficacy in monotherapy, and in combination with other anti-acne agents, an excellent tolerability profile. Cross out bacteria with Nadixa. New antibiotic treatment for acne vulgaris and skin bacterial infections. Acne is one of the most common disorders treated by dermatologists and other healthcare providers, with more than 90% of the world's population being affected by acne at some point of their life. Acne vulgaris, or simply acne, is a common disorder affecting the sebaceous follicles with several factors that influence its development. Since its treatment would require antibacterial action, antibiotic resistance is an issue to consider. In dealing with acne vulgaris and other bacterial infections such as impetigo, carbuncles, and furuncles, entrust your patient's skin to effective treatment with less worries about resistance with Nadixa. Nadixa is nadifloxacin, the first topical quinolone indicated for acne vulgaris and bacterial skin infections. It has a broad-spectrum antimicrobial activity that works mainly by inhibiting DNA gyrase, which then prevents bacterial activity and causes cell death. With this mechanism of action, there is a very low resistance compared to macrolides and lincosamides. It also inhibits the production of pro-inflammatory cytokines and suppresses androgen reception transcription activity to 29.8%, giving it anti-inflammatory and anti-androgenic activity on top of its antibacterial activity. Nadifloxacin has been proven to be effective compared to placebo in several studies and was shown to have similar efficacy to erythromycin in reducing acne lesions with no resistance generation in 12 weeks. When used in combination with adapalene, nadifloxacin showed a higher and earlier reduction in inflammatory lesions. It also showed significantly less erythema and less proportion of dryness compared with adapalene monotherapy. In terms of safety, the general tolerance of topical nadifloxacin treatment was rated good or very good by 98% of investigators and 96.6% of patients. In combinations, nadifloxacin does not lead to substantial reactions versus drugs alone. Nadixa is available in 10 mg per gram 1% aqueous cream solution. Nadixa offers strong broad-spectrum antimicrobial activity, low resistance rate, additional anti-inflammatory and anti-androgenic effects, overall efficacy in monotherapy, and in combination with other anti-acne agents, an excellent tolerability profile. Cross out bacteria with Nadixa. New antibiotic treatment for acne vulgaris and skin bacterial infections. Acne is one of the most common disorders treated by dermatologists and other healthcare providers, with more than 90% of the world's population being affected by acne at some point of their life. Acne vulgaris, or simply acne, is a common disorder affecting the sebaceous follicles with several factors that influence its development. Since its treatment would require antibacterial action, antibiotic resistance is an issue to consider. In dealing with acne vulgaris and other bacterial infections such as impetigo, carbuncles, and furuncles, entrust your patient's skin to effective treatment with less worries about resistance with Nadixa. Nadixa is nadifloxacin, the first topical quinolone indicated for acne vulgaris and bacterial skin infections. It has a broad-spectrum antimicrobial activity that works mainly by inhibiting DNA gyrase, which then prevents bacterial activity and causes cell death. With this mechanism of action, there is a very low resistance compared to macrolides and lincosamides. It also inhibits the production of pro-inflammatory cytokines and suppresses androgen reception transcription activity to 29.8%, giving it anti-inflammatory and anti-androgenic activity on top of its antibacterial activity. Nadifloxacin has been proven to be effective compared to placebo in several studies and was shown to have similar efficacy to erythromycin in reducing acne lesions with no resistance generation in 12 weeks. When used in combination with adapalene, nadifloxacin showed a higher and earlier reduction in inflammatory lesions. It also showed significantly less erythema and less proportion of dryness compared with adapalene monotherapy. In terms of safety, the general tolerance of topical nadifloxacin treatment was rated good or very good by 98% of investigators and 96.6% of patients. In combinations, nadifloxacin does not lead to substantial reactions versus drugs alone. Nadixa is available in 10 mg per gram 1% aqueous cream solution. Nadixa offers strong broad-spectrum antimicrobial activity, low resistance rate, additional anti-inflammatory and anti-androgenic effects, overall efficacy in monotherapy, and in combination with other anti-acne agents, an excellent tolerability profile. Cross out bacteria with Nadixa. New antibiotic treatment for acne vulgaris and skin bacterial infections.
From the University of the Philippines College of Medicine, Postgraduate Institute of Medicine, in partnership with the University of the Philippines Medical Alumni Society, spearheaded by its Davao chapter. Welcome to the UP College of Medicine Grand Scientific Symposium 2021. I am Dr. Kathleen Rose Mata, and I will be your host for today.
May we request everyone to pause for the national anthem, followed by the invocation, to be led by Dr. Eugene Barinaga of UPCM Class 2002.
Bayang mag-ibiw, kalas ng silanganan, alab ng puso, sa dibdib mo'y buhay. Lupang hinirang, duyan ka ng magiting, sa manlulupi, di ka pasisihil. Sa dagat at bundok, sa simoy at sa langit mong magaw, may hilagang tula at awit sa paglayang minamahal. Ang kisap ng watawat mo'y tagumpay na nagilingin, ang bituin at araw niya kailan pa may di magdidilim. Lupa ng araw ng walang ating pagsinta, buhay ay langit sa piling mo. Aming ligaya na pag may mga api, ang mamatay ng dahil sa'yo.
Lord, unveil my eyes, let me see you face to face, the knowledge of your love as you live in me. Lord, renew my mind as your will unfolds in my life, in living every day, by the power of your love. Hold me close, let your love surround me. Bring me near, draw me to your side. And as I wait, I'll rise up like the eagle, and I will soar with you. Your spirit leads me on in the power of your love. Hold me close, let your love surround me. Bring me near, draw me to your side. And as I wait, I'll rise up like the eagle, and I will soar with you. Your spirit leads me on in the power of your love. And I will soar with you. Your spirit leads me on in the power of your love. And I will soar with you. Your spirit leads me on in the power of your love.
To kickstart our program, let us welcome the Organizing Committee Overall Chair and UPMAS Davao Chapter President, Dr. Maria Assunta Cecilia Serrano, for her opening remarks.
Magandang hapon po sa inyong lahat. Binabati ko po ng mainit na pagtanggap ang ating mga malugod na panauhin, mga opisyal at namumuno ng mga kagawaran ng gobyerno at mga pinuno ng Universidad ng Pilipinas, Manila at Kolehiyo ng Medisina, ang ating mga mahuhusay na tagapagsalita, mga profesor par excellence at kapwa masisipag na manggagawa sa pangangalaga ng kalusugan. Ako po si Dr. Assunta Cecilia Realobit Serrano na naniniwala na ang kalusugan ay isang pangunahing karapatan ng bawat Pilipino at ng bawat mamamayan sa mundo. Quote, health, which is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity, is a fundamental human right, unquote. The 1978 Declaration of Alma Ata resounds in wanting to be equitably addressed in our current state of pandemic. Abrigo and Ortiz in their 2019 paper cited WHO 2016 data that in the Philippines, only less than 25% of cities and municipalities have health human resources density above the 41 physicians, nurses, and midwives per 10,000 population recommended by the World Health Organization. 2019, bago magpandemya, buwan ng Setyembre, halong pangamba at hamon ang aking naramdaman noong tinatag ang pinakaunang Regional Alumni Society ng aming mahal na kolehiyo ng medisina sa rehiyon ng Davao sa Mindanao. Naibsan ang pangamba ng hamon. Naging inspirasyon ang hamon at dedikasyon ng dekano, direktor, executive director at pangulo, dekano ng UP College of Medicine na si Dean Charlotte Chong, director ng Postgraduate Institute of Medicine na si Dr. Teresa Cruz, executive director Dr. Lilibeth Genuino, and president o pangulo ng UP Medical Alumni Society na si Dr. Jean Toral. 2020, lumabas ang balita ng pandemya. Nabuo itong minsan sa 6 na taon na kaganapan, ang UP College of Medicine Grand Scientific Symposium 2020, na ang layunin ay may bahagi sa kapwa manggagawa sa pangangalaga ng kalusugan ang mga bagong kaalaman sa siyensya at pagsasanay sa paggagamot. Ngunit, pandemya ang nagudlot ng kaganapan nito. 2021, kasagsagan ng pandemya at ang kalakip nitong paghihirap, pandemya rin ang nagudyok na maganap ito ngayon. Naging inspirasyon kayong lahat ng ating mga medtechs, pharmacists, doktor, midwives at nurse na nasa harap ng hanay ng pangangalaga sa kalusugan. Ito na ang araw na gaganapin ang ating pag-aaral kasama ang mga eksperto sa kani-kanilang larangan sa mga susunod na 3 araw. Nais namin na maibahagi sa inyo ang bagong kaalaman at pagsanay upang magamit natin ito sa gitna ng kasalukuyang pandemya at lalo nang maging laging handa sa pagtugon tungo sa pagiging malakas sa pangangatawan at pag-iwas sa sakit sa mga taon na haharapin pa natin. Sa ngalan ng komite na bumubuo ng UP College of Medicine Grand Scientific Symposium 2021, inaanyayahan ko kayong makibahagi sa 3 araw na pag-aaral. Sana ay maiuwi natin ang hamon ng pakikipagtulungan sa lahat ng sektor ng bayan para sa kalusugan. Alalahanin, ang kalusugan ay karapatan.
Thank you, Dr. Serrano. You can now visit our virtual exhibit and commercial booths through the links found at the convention website with the address upcm-symposium.upm.edu.ph. This exhibit is available to everyone for a whole month. thank you to our sponsors for supporting this event. We now move on with our program. Please help me welcome the Dean of the UP College of Medicine, Dr. Charlotte M. Chong, to give us a message.
Welcome, officials of the UP Manila, led by Chancellor Carmencita Padilla, our distinguished roster of speakers, led by our keynote speaker, Dr. Beverly Lorraine Ho. This will not happen, of course, without the incredible work and spirit of collaboration of the men and women from the first chapter of UPMAS, the UPMAS Davao chapter, led by Dr. Maria Assumpta Cecilia Reyolivich Serrano, and our dream team of alumni, the PGM IM Director, Dr. Teresa Gloria Cruz, the President of the UP Medical Alumni Society, Dr. Lara Therese Alentahan Aleta, as well as the Board of Directors of UPMAS, for their full support. And therefore, I would like to welcome all also the esteemed members of the faculty of the college, our professors, and our students. This will go down in the history not only as the 22nd GSS, as the one last held was in 2014, but it will go down in history as the first ever virtual Grand Scientific Symposium in the history of the UP College of Medicine. After 1 year of planning, it is finally unfolding this afternoon. The theme UP Dates, Bridging Science and Practice for Health Filipino, Forging Ahead, highlights the 18 symposia speakers, as well as the other members of our UPCM community involved in the relentless pursuit of the UP College of Medicine vision and mission, despite the greatest challenges posed by this still surging pandemic. I myself chaired the 13th Grand Scientific Symposium in 2006 that focused on emergencies and disasters. And even then, we actually talked about the looming pandemic given the cycle of pandemics experienced in the course of history. It behooves all of us to give our share in the implementation of the most ambitious health program that we all have dreamed of for our people, and that is universal healthcare. As I speak, the UP College of Medicine is determined to work with CHED, DOH, and the PRC for crafting a roadmap, SMART, that stands for Strategic Medical Accelerated Roadmap for Tomorrow, not only on the heels of RA 11223 or Universal Healthcare Act, but also because of the Dr. Sabayan Bill, as well as the Human Resources for Health Master Plan. The next 3 days will certainly not only highlight the trajectory of pushing our medical practitioners to contribute to better care for our countrymen in the midst of a COVID-19 pandemic. There will also be other focus sessions for cardiovascular, pulmonary, gastrointestinal, endocrine, mental health conditions, and cancer. Not only will these sessions inform our participants on how specialists and GPs can break barriers to make quality healthcare more accessible to our community and primary healthcare practitioners, but it will also highlight the advocacies in having such knowledge trickle down to empowering our partners in taking care of the health needs of our fellow Filipinos. Again, congratulations to all of you for making time for the Grand Scientific Symposium this afternoon, because I know there will be lots of pearls of practice and meaningful discussions that will enrich your continuing education, as well as spark ideas for collaboration to help elevate the health status of our country in the new normal as we emerge from this pandemic. May we all emerge better, kinder, and wiser after the 22nd GSS is over. Mabuhay po tayong lahat.
Thank you, Dean Chong. We will also be hearing a message from our dear Chancellor of the University of the Philippines, Manila, Dr. Carmencita Padilla.
Dean Charlotte Chong, PGH Director Gap Legazpi, Assistant and Associate Deans, Department Chairs, Program and Unit Heads, Faculty, Presenters, Guests, a pleasant morning. I am pleased to welcome you to the UP College of Medicine Grand Scientific Symposium being resumed through this virtual edition. For many graduates and alumni of the College of Medicine, the GSS is more than a tradition and a continuing activity. It has become a major part of the journey and transformation of medical students and doctors into proficient and holistic health professionals. Every year, during the pre-pandemic time, the GSS is a much anticipated event, not only within the UPCM community, but also by physicians nationwide. Each GSS has been noted for its ability to push boundaries and blaze new trails in terms of topics or themes tackled. And this is why attendance in every GSS has always been high. Physicians and allied health experts all over the country and representing different universities and institutions find the GSS an excellent and immense platform to share exciting new findings, facilitate scientific exchange, and generate opportunities for scientific engagements, such as identifying potential new collaborations. Top scientific breakthroughs and cutting-edge researches are presented and discussed, while comprehensive updates on the themes at hand are discoursed. This year's symposium, entitled UP Updates, Bridging Science and Practice for a Healthy Filipino Forging Ahead, highlights once again the pivotal role of science and research in optimizing the health of our nation and our people as it confronts current and future challenges. As if compensating for the years it was not held, the 2021 GSS brings into clearer focus several topics and subtopics for discussion. Universal health care rollout, COVID-19 101, updates and forecasts, up morbidities in the Philippines, and threats to wellness. While the COVID-19 pandemic has brought about new health problems that are still evolving, it has also unleashed enormous knowledge, innovations, and technologies never before seen in our time. This symposium is significant and beneficial for all of us, committed to a lifetime learning in this age of staggering challenges and unprecedented shifts in the health and education landscapes. Let us congratulate and thank the UP Medical Alumni Society and the UPMAS Davao chapter for working hard and coming up with these very pertinent topics. I can imagine the sharing and exchange of experiences, best practices, lessons, insights, and wisdom gained during the pandemic for the benefit of patients. This activity is a facet of our UP Manila University and Dear College of Medicine, which sets apart and highlights our commitment to relevance and excellence. On this high note of optimism, we look forward to your full, active, and committed engagement and participation towards a successful forum. Maraming salamat po at magandang umaga muli.
Thank you, Chancellor Padilla. Let us now give the floor to Dr. Catherine Rua, Chair of the Scientific Committee of this symposium, to give us an overview of our 3-day course.
Good day, everyone, and welcome to the UP College of Medicine Grand Scientific Symposium for 2021. For most of us, this will not be your first Grand Scientific Symposium experience, but for some of us, it is. And so it is with excitement that we bring you a series of lectures and learning activities for the next 3 days. Our theme for this year is Updates, Bridging Science and Practice for a Healthy Filipino Forging Ahead. And the thing to remember here is that, yes, we study about science, about the current status of the body of knowledge, but then the goal really is to move forward and help more people. And so the first 2 topics are very hot topics during these times. The first will be universal health care, and the second is on COVID. And for these 2 topics, we will be learning about the updates and also forecasts. The first one for universal healthcare is very relevant for all of us because it will strive to explain how to bridge the specialists and the primary care providers under the umbrella of universal healthcare. The next one will be on COVID, where we discuss microbiology, immunology, diagnosis, treatment, infection prevention, and control. The next session on the second day will be on addressing morbidities, which are very common in the Philippines. So we specifically made it a point to choose topics on the top of the list of the M&M list of the country. So the first one will be on hypertension and also diet. For the diet, we're going to talk about the DASH diet, fad diets even, and also supplements. The next one will be pneumonia. And here we will listen to the clinical pearls on the management of pneumonia through the different age groups. So we have a speaker who will talk about management of pneumonia for pediatric population, and also a speaker who will speak about management for adults and geriatric patients. The third topic under this morbidity umbrella will be diabetes mellitus. So it's going to be bullseye, because in diabetes mellitus, we really want to hit the targets. So the first speaker will talk about the standard of care for diabetes. And the second speaker will talk about chronic kidney disease, which is very important, as diabetes is the most common cause of chronic renal failure in the country. So for the third day, we're going to move into addressing disease prevention and wellness. So here we're going to talk about aging, and we will have an exciting he said, she said type of discussion. We will have one clinician who will talk about andropause, and for the she said part, somebody's going to talk about menopause. And then we're going to talk about mental health, which is very important, especially during this time. And under mental health, we're going to talk about suicide and depression in the adolescent population, and also anxiety and other mental health concerns for the geriatric population. And finally, we're going to talk about cancer. This is not just going to be the usual approach to cancer, because we're going to focus on early detection and management of cancer, so that we prevent, so we catch it early and prevent complications from late stage cancer. So I hope that you will enjoy the learning activities that we have prepared for you for the next 3 days, and that after the 3 days, you will be able to apply what you have learned in this course and help more people for the days to come. Thank you so much, and welcome once again.
Thank you, Dr. Roa, for that summary. We are very excited to begin with the first focus session, which will be on universal healthcare. The chair of this session is Dr. Lynn Redoble, a notable community medicine practitioner based in Davao. Joining her as co-chair is Dr. Eleanor Alba Concha, currently the Chief Training Officer of the Southern Philippines Medical Center.
Para sa akin po, ang universal healthcare or kalusugang pangkalahatan ay ang pagbibigay po ng serbisyong medikal sa bawat Pilipino, mapabata man o matanda. Layunin po ng universal healthcare ay ang pagbibigay ng highest possible quality of healthcare that is efficient, that is accessible, and that is equitably distributed. Marami po tayong serbisyo na makukuha sa universal healthcare. It could be general health services, it could be preventive health, or specialized care medicine such as your geriatric care or palliative care medicine. Layunin din po ng universal healthcare ay ang pagbibigay ng financial risk protection, which is for me isang malaking bagay sa isang mamamayang Pilipino, dahil hindi na po sila mamroblema kung saan po sila maghahanap ng pambayad. Dahil malimit po, ito po ang dahilan kaya sila natatagalan na kumonsulta ng doktor o pumunta sa hospital para po magpagamot.
Isa sa mga ipinapatupad sa ilalim ng Universal Healthcare Law ay ang mas malawak na coverage para sa mga outpatient at preventive services. Isa sa mga pinalawig ng gobyerno ay ang outpatient benefit ng PhilHealth sa pamamagitan ng tinatawag na konsultasyong sulit at tama o konsulta package. Sa package na ito, mas expensive na ang serbisyong pangkalusugan gaya ng outpatient diagnostics, mga basic ng gamot at konsultasyon sa mga primary care provider. As of July 2021, mahigit 100 na accredited consulta providers na. Bilang mga early adopters sa iba't ibang bahagi ng Luzon, Visayas at Mindanao mula sa public at private sector.
For me, the universal health care is an effort of the government to make sure that the essential health services are delivered without interruption to the people, whether rich or poor. As a COVID ICU nurse, I am very thankful that the government covered all the costs for the treatment of COVID patients, including costly laboratory workups, expensive medicines such as tocilizumab, remdesivir, and other necessary procedures such as hemoperfusion, hemodialysis, and other medical and surgical procedures. This is such a huge relief for the family, the patient, and even for us, the healthcare workers.
We would like to invite our Dean, Dr. Charlotte Chong, back to the virtual stage to formally introduce our keynote speaker.
A pleasant afternoon to all the participants in this year's Grand Scientific Symposium. Our keynote speaker this afternoon on the topic of universal healthcare completed her Doctor of Medicine degree as a member of the University of the Philippines College of Medicine class of 2010. She subsequently earned her Master in Public Health at Harvard University in Boston, Massachusetts. She's currently the Director of the Health Promotion Bureau of the Department of Health. She previously held positions as Division Chief at the Department of Health from 2016 to 2019 and as a consultant to the Asian Development Bank from 2015 to 2016, a Strategic Initiatives Officer at QualiMed Health Network from 2013 to 2014, and as consultant to the Alliance for Improving Health Outcomes from 2013 to 2016. She was designated as Fellow of the Equity Initiative for Southeast Asia of the Atlantic Institute in 2017, and appointed as Fellow of the Maurice Greenberg World Fellows Program at Yale University in 2019. Related to her specialization in public health and health policy, she was part of the National Health Insurance for Universal Health Care of the Asian Development Bank in 2016, participated in the Future of Global Health Procurement as a side event of the UN General Assembly in 2019, and presented in the Health Systems Reform in the Philippines at Yale University in 2019. Ladies and gentlemen, it is indeed my privilege to lead you in welcoming a model public servant, one of the bright stars in the Department of Health, leading this agency into new paradigms of service to the Filipino people. Dr. Beverly Lorraine Ho, Doc Bev, the virtual floor is now yours.
Good afternoon, ma'am. Good afternoon, Dean. And good afternoon, everyone. Ma'am, thank you very much for the kind introduction. Good afternoon, particularly to all my teachers and former colleagues, ka-duty mates, mentors, fellow profession, and also colleagues in service. So maraming salamat po, and thank you again for this opportunity to exchange ideas with all of you regarding the future of our healthcare system. So allow me to share my slides now po. Today, I was given the assignment of talking about how to bridge specialists with primary care. Allow me to begin by outlining some of the objectives as we started out with determining what goes into this presentation. And for that, I'd like to thank our small group, the organizing committee behind this session, because we actually had a very fruitful brainstorming and we enjoyed it a lot. No? So first of all, the objective is really to trigger reflection, discussion, or even already some changes on how to make our curriculum, current business or practice models, wherever you are practicing, and even your work, charity work, or CSR work for those of you who are in a corporate setup, making them primary care enabling. No? And to make this happen, we will go through three parts of the presentation, which is to allow you to appreciate the role of people-centered primary care, facilitate understanding of some of the enablers of this primary care that we're talking about, and finally, some practical ways for you, all of you, to become catalysts in your own ways in moving us towards UHC in your specific province and citywide health systems. So for the first part, let's dive deep in. Oftentimes, these two terminologies get thrown in and interchangeably. So primary healthcare and primary care. I guess the easiest way I could digest both concepts is really that PHC is actually more an approach or a philosophy, while primary care describes a particular set of services at a level, which is usually the entry level into the health system. However, if you talk about it, both can actually encompass promotion, disease prevention, diagnosis, treatment, until palliation. So actually, they're not entirely different, but they're very, very actually much related. So in this presentation, we will pertain to people-centered primary care, which means it's primary care that imbibes the entire concept of primary healthcare. So when we talk about primary healthcare, the key term will really be full participation of the people and the community. And when we talk about primary care, we're talking about the coordinated way in which we allow the patient or the person, kahit wala pa siyang sakit, to actually navigate the system supported by the actors that are working in primary care. So before we can actually dive deep into what we will talk about, I think it's important to step back a bit and recognize the principle for how we are going to be discussing primary care. And a huge part of that understanding is going to be summarized in this slide. If you see 40, 10, and 30, that's around 80% of healthcare or of the population's health can be attributable to socioeconomic factors, or where you live, actually, how you grow up, who your parents are, the physical environment, and also the health behaviors. And interestingly, only 20% of the population's health can be attributed directly to healthcare services. Oftentimes, because we are in the service of health, syempre the 20% becomes the most apparent to us. But I'm sure in your practice and in your dealings with your patients, many of us know, especially kung sa PGH, sa OPD, diba? Pag magreseta ka sa pasyente at hindi niya nabili, you won't get what you will actually want from that 20%. So just by showing this, we want to be able to emphasize the important role of multisectoral work in order to address those 80%. And of course, how better we should become in order to make this 20% really worth the money that the system, the people are paying for. So in summary, when we talk about UHC, we actually want to protect and enable Filipinos to care for not just for themselves, but for their community. And for us, people in the health sector, to be able to take care of our countrymen when they actually need the services. So now the question is, when people need the services for that 20%, where do they go and what do they need? So this was a landmark study done in the New England Journal of Medicine long ago, but still holds quite true. So if you see, it just summarizes that for every 1,000 population. So this study was repeated in other contexts, no? And similar yung results. For every 1,000 patients that you have, you might have around 800 who will report symptoms, 300 who will consider seeking medical care, etc., etc. No? And as you go down, you will really see that most of them would actually seek care, no, from a primary care provider or an outpatient clinic. And interestingly, perhaps less than one, no, will go to an academic or medical center, and around 8 will get hospitalized in a tertiary or secondary or primary care facility. So parang what this is really telling us is, where is the need? No? And so, are we there? Are the people working in the green box? Are we where people need us to be? No? And I think many of us know the answer, and perhaps that's also the reason why this was a topic that was outlined, no, or included in this GSS. So when we talk about the primary healthcare or strong primary healthcare or people-centered primary healthcare in the global level, we're actually pertaining to this system wherein it's able to address more than 80% of people's common health needs. And obviously, we know that that's quite different with more specialized, no? But then across many of our specialties, we actually have the common conditions, diba? And that's what's part of that 80%. The system is also efficient in detecting and preventing and managing people's illness before they become too expensive to treat. Again, if you're practicing in a tertiary facility, particularly a government hospital, academic center, itong second bullet is really hits close to home. The system is fair and equitable, providing all people with access to essential services in their community. It protects global health security, very, very relevant in our times, by helping communities detect and stop local outbreaks before they even become global pandemics. And finally, saves and improves lives, no, with fewer children dying before their 5th birthday, and more importantly, longer, healthier lives. So I think for bullet 4, we already are seeing it. No, it doesn't mean that when you're a high-income country, you can escape this part. Because when the community is actually not cohesive, not empowered to go and perform what it needs to perform in a primary healthcare setup, and if they're just mere beneficiaries of health services, it will be difficult. And we've seen it, even high-income countries that spend so much money on their healthcare system, they're also unable to, say, control certain outbreaks. So in this graph, we summarize how much our country is spending on primary healthcare. On the left-hand side of the screen, you see a graph of the various European countries and their investments in primary care. And I guess for many of you who've also been training abroad, I've heard from some specialist batchmates or actually seniors, when they came home from Europe, the first thing they told me was, oh, totoo pala, no? Pwede palang maging totoo yung UHC. Bakit hindi pa natin yun gawin sa Pilipinas? Kasi they really experience good primary care setup, which translate to good specialist care practice. So here in this slide, we just summarize to you how much our country is spending. And on average, Europe spends around 13.1% of their total health spending to primary care. On the contrary, countries like America, United States spends around 5 to 7%, and tayo, no, sa Philippines, around 4%. And most of this is even medicine span, outpatient medicine. So kulang, no? Kulang, and that's also perhaps the reason why the field isn't growing, di ba? Kasi inevitably, there are market forces that will lead people to go to also places where they can actually earn a keep. So when we reviewed global studies, this is a summary done by WHO around what is really the benefit of primary healthcare? No? So does it really deliver as promised? And apparently, all the evidence actually point to yes. No? So it can lead to improved equity, improve health outcomes like life expectancy, all-cause mortality, even mental health outcomes, and improve health system efficiency. So overall, syempre, at the end of the day, these can translate to economic benefit. But I guess what's important for us is we know it can lead to lower healthcare costs, which is important, particularly in our setting. It can lead to better health outcomes, more important para sa ating mga concern talaga sa health outcomes. And more importantly, it can actually lead to better equity, no? Meaning more people can access services and it's really not skewed towards those who can only afford it. So with that, one of the main goals then of the UHC law is to institutionalize people-centered primary care or primary health care. So specifically for primary care, every Filipino family is matched to a primary care provider who ensures that they receive the services that they need in facilities within the healthcare provider network. No? Another way of expanding is really to make sure that people are in communities wherein the community is actually empowered. Diba? So in a schematic, it just looks like this, no? Someone who's in a community, whether you're sick or you're healthy, you're able to have a primary care provider who helps you navigate the complicated system. Now, obviously, there will be times that you will bypass the system when, say, for example, may emergency, you will really need to go directly to a hospital. But the idea is in the future, no, and this might take a generation before we actually finally put it in place, this will take time to build. And later on, you will see that many of the building blocks for this system will still have to be worked out. So under the UHC law, it is also important to note that it's not just about benefiting patients, but equally important are benefiting healthcare providers. I think when we put it out there, it is important to note that the healthcare providers are foundations of a working system. And when healthcare providers are unhappy and unsatisfied, evidence also shows us that the system is also going to suffer. So for the patient in particular, we want to be able to reduce their risk, no? And we want to be able to improve their ability to decide, no? Meaning, kung pwedeng hindi magdesisyon na at yung default, yung healthy choice yung i-choose nila, that's what we want. Second is to improve their health literacy. But this is related to the first point wherein we know, no? That even if, for example, some of our classmates or some of our friends who are in the healthcare sector, even if they know the risk, they're actually very health literate about, say, smoking, they actually still do it because the infrastructure or the environment isn't enabling enough to get them to stop. And then the UHC law also wants to increase access and affordability, but also related to that is increasing quality and responsiveness of services. By responsiveness, we mean that it's actually decent care, hindi ibig sabihin, oh, nabigyan na kita ng serbisyo, but I do it in a very rude manner or in a way that your privacy is actually compromised. No? So hindi pwedeng ganon. And then from the provider side, we also talk about an enabling environment, which means the providers are sufficient, no? That they don't have to work double, triple time because no one else is in their area to serve the population. Increase also in system literacy, knowing how to navigate or making it easy also for the providers to navigate the system. Of course, decent and predictable pay, which is kind of impossible with the way our current system is, no? Because it's largely based on who turns up in your clinic and how much, no? You're able to, how much patients you're able to keep, no, for many years. And so the idea is in the future, even newer graduates may actually move on to another model of pay, similar to how it's being done in other countries, wherein they actually have work days, they have leave days, but predictable pay, which in turn allows the facilities that are employing them to also make the services predictable. So they can actually really say that, oh, in our hospital, surgeries of this type are this much because the pay for the providers is actually predictable, no? Or masasabi mong part na siya ng fixed cost niya instead of variable cost. And then finally, allow sufficient learning opportunities. I guess this is how I'll just frame it for the provider. As we know in the country now, the setup is, if you're a specialist, you also need, because you don't have a choice, you also need to be sort of like be a generalist, no? Because there just isn't enough people serving the country. But time and again, we've heard, no, from many people na, okay, I trained for this specialty because I wanted to be able to practice my craft. No? But I'm unable to do so because I need to see so many general patients, or I need to be, paano ba yun? I just need to earn my keep, no? And it's the general patients that will actually allow me to do that. So, hindi natin siya magagawa, hindi natin siya ma-address one by one, no? But it's really a system challenge. So, at the end of the day, with all of these changes that we want, we actually want just three things, no, for both the patient and the provider. Both will be happier and healthier. Both will not worry the other one about what he or she will pay, and the other one for what he or she will earn, because it's actually a decent and even lucrative amount of pay. And then finally, satisfied for the patient and fulfilled for the provider. However, I must also note that in thinking through UHC, we cannot detach ourselves from the reality that the current or our local health system is devolved. No? And that's why when we always talk about UHC and primary healthcare, we say that this can be achieved one province, one city, or even one community at a time. No? So you can't run UHC just only directly from the top. No? Actually, people within a particular community and particular geographic area really have to work hand in hand on it. And that's actually a good opportunity for all of us in this webinar. Really think about what is our role and what can we do to drive UHC and primary healthcare within our area. So, what now are the enablers that we need to have for primary healthcare? So, first of all, we need to recognize that all of these will require collaboration. And collaboration in different fronts, in different styles, will actually be apparent, no, as we discuss each one of them. So first, I briefly talked about it a while ago, is really increasing health literacy and choice architecture for healthy behaviors. So we mentioned it in a few slides back that 80% of a patient's or a population's health is actually out, no, of our control. Kasi it's not within the clinic or it's not within the hospital that we can actually address this. So this was the first and only, as of this time, National Health Literacy Survey done in the Philippines back in 2018 by the UPCPH. And you'll see here, the people in NCR, Visayas, Luzon, Visayas, and Mindanao were rated, no, in terms of their comprehensive health literacy. So this is a standardized scale rating, no, wherein there are 47 items that someone is asked to read, and then they will have to answer questions related to this. No? So it doesn't ask about do you smoke or do you not smoke, no? But it provides information. For example, okay, these are the components of tobacco, there are carcinogenic, etc., etc. Okay, then what will you do? No? So it already appraises how well a person is able to process that information and decide for themselves. No? And you'll see here that those with sufficient comprehensive health literacy are near 40%. No? And when you even go to excellent CHL, it's already at 8.25%. No? And this has far-reaching implications, of course, in not just the 30% behavior part that we're talking about, but really can spill over into the parts where there's already healthcare service provision. Diba? Kasi when health literacy is good, when you advise your patients, they're more likely to also follow that advice. Diba? When health literacy is good, their likelihood of seeking care in the very first place is also going to be better. So with this, we have summarized the healthy behaviors that people need to practice in these 7 buckets. No? So diet and exercise, environmental health, vaccines, substance use, mental health, sexual and reproductive health, and violence and injury prevention. And over the course of the past many years, we've actually seen both primary care practitioners as well as specialists, no, who've been helping out in many of these work. No, unfortunately, in the past, probably when people talk about health literacy, the first thing that comes to their mind is, I may poster or my IEC, my brochure, no, or Mother's Class ba yan? Yes, they're equally still as important. But I think now what we are emphasizing is the choice architecture includes policy. So for smoking and binge drinking, for example, or alcohol intake, our response was syntaxes, right? For sugar, increased sugar intake, there was the SSB taxation, no? When we talk about violence and injury prevention, we have Safe Kids, Doc Rafi from UP College of Med before leading this work alongside many surgeons now, helping teach children how to cross streets. So I guess what we wanted to say here is that this piece of work now moves beyond just advocacy, which is typical, kailangan pa rin siya gawin, but into something more sustainable. Can it be a policy or can it be a program? And it indeed can be done as a program of work in communities, in learning institutions or schools, in workplaces, or even in healthy clinics and hospitals. So we all know that we actually don't spend a lot of time in our homes, no, but our waking hours are really spent outside, no, whether that's a community, that's a school, or that's our workplace. And so we now have, because of the UHC law, also a renewed push to actually reimagine what is the health work that we do in these spaces. So for example, for healthy schools, yung traditional po no, na mindset din is, pag healthy schools, isama natin yan sa curriculum. Or pag healthy schools, kailangan maayos yung clinic sa eskwelahan. But we know that it goes beyond that. No? We want to have a community in place within the school, that the environment is actually very supportive of, say, gender issues. Is there a safe space for people to report them being violated in their homes? Is there a way for the school to actually work with the vendors outside, diba? Kasi if we talk about bawal mag-smoke sa school and, you know, beyond 100 meters, but if the smaller stalls outside of your schools won't cooperate, then it actually won't work out. No? So these are the things that we want to improve on in the coming years. Actually, we've started na po, no? But it's really around thinking around beyond just information and education communication materials. For example, in school and clinics din po, we currently have a project and that's being led by another UPCM grad, so si Doc Nigo, and we're working towards helping healthcare workers manage stress, no, using various forms of behavioral nudges. So that could be in the form of a screen, a photo in their cell phone. It could be a poster with a QR code that reminds them to meditate, for example, or even just do breathing exercises in the midst of their duty, or someone checking in, on them at the start or at the end of their duty, for example. So this piece of work will be expanding and should be expanding in order to help us not bring so much more people into a condition wherein it's going to be very, very difficult for us to treat them anymore. Now, related to our work on healthy communities, we are sharing with you here some of the playbooks that we've done. We talked about having policies and programs in place. And actually, in some communities, they do have the capacity to issue out resolutions or mga ordinances in the provinces that will make health promotion a little bit more stronger than everyone else. For example, in our active transport playbook, this is actually a full implementation ready playbook wherein there's already a template ordinance that the local government units can use. How should they budget for bike lanes? How much paint will they need to use? How much orange cones will they need to buy in order to build X kilometers of bike paths, for example. So there are different versions of these playbooks, but all of them collectively target the 7 behaviors that I talked about. And in many of these, we did have a lot of groups that help support our work on this. For example, our continued work on smoking has really been with many of the pulmonologists, right? Our work on peer support groups for children are really with many of the pediatricians. Of course, needless to say, for vaccines, it's the same, no? And then we did have a lot of internists also helping us in our active transport, advocacy, policy, and programmatic work. So all of these are available online, ready to be downloaded, and you can actually use them in your setting. No? Now, the second part of the enabling, what are the other enablers of primary care, would really be governance, or defragmenting how the system is currently set up. So on the left-hand side of the screen, you actually see our setup pre-devolution. So here, everything is connected to the DOH central office. But currently, we're actually devolved, so we're cut off. Different yung second box, which is our regional offices or the provinces from the municipalities. And so under the UHC law, the idea is to try to connect them once again, because there's really no incentive for the public health clinics to work with the hospitals when they're incentivized very, very differently. And so to make this happen, we actually have this local health system maturity model that was created to finally tell LGUs what is the roadmap to get to UHC. So it contains the 6 building blocks, 10 different characteristics that they have to achieve, and what the key results areas are, with 3 levels of progress for each. So I don't think you need to to look at this intensively, but this is really mostly for our LGUs. So those are the 6 building blocks, the 10 areas that they have to work on. That would include HRH management and development, or health human resource. Health promotion is also there. And then for each one, there's actually levels of progress. So kunwari, for health promotion campaigns, nasa preparatory level ba sila? Nasa organizational level na ba sila? Or functional na sila? Of course, the idea is everyone reaches functional level 3 for all 10 indicators. But each would have probably different phases. So yeah. The third third enabling factor is really to make sure we have more health facilities. And we actually have a shortfall of around 3,000 primary care facilities, for which we would hope to build or to close the gap by this strategy on the right-hand side. Meaning, if the area has high gap but low capacity, that would be the priority where government will build it. But if the area has relatively low gap and high capacity, kunwari, NCR, no, you have a lot of private sector that can build, then that's category 4. Last magbe-build yung government in those areas. As for health workers, we know that we need to retool people who have traditionally been not formally trained, no, into primary care, and be able to set up what their competencies are. And their competencies range from providing services to actually being able to implement public health programs. Related to our HR work also is to task shift, no? To formalize task shifting and task sharing. Task sharing would mean that the primary care provider isn't just a single person, but actually a team. No? So there are things in primary care similar to, say, counseling that will take a lot of time, 30 minutes, even an hour, no, to help someone, for example, breastfeed better. But that would probably make or use up so much time of a clinician that you will actually want another type of provider to take on those roles. The fifth enabling act for primary care is instituting standards of care. So for many years, DOH has been not as active in this front, but in recent years, with the help of many of our alumni, but also with the help of many specialists, we have been able to publish more clinical practice guidelines, which we are now translating to various SOCs, no, or standards of care. And these should inform in the future benefit packages, even training, capacity building, and curriculum enhancement, among others. An example of what we are now trying to do with the many specialist societies now is to outline which are conditions that we are going to be comfortable having primary care providers look at, and which among these, no, how do we provide them job aids, guidelines, etc., so that they can do their job better. Unlike yung paradigm before, let's not let them do it. Usually, mali-mali yung diagnosis. Here, there's really a collaborative effort, no, na hindi namin yan kaya lahat tingnan. Someone at the forefront or at the front line needs to be able to see them and diagnose them correctly. So this is just an example, but a lot of these inputs really came from many of our specialist societies. So meron din kaming version for children, no? So what is really within the primary care level and what should actually be referred outside na. So the sixth part is really aligning incentives or financing. And the goal is really to have, as what the video has talked about, comprehensive outpatient service coverage, including, no, paying for specialist primary care services or specialist outpatient services before moving on to a comprehensive inpatient coverage. And related to this, there's currently aligning of processes because of the laws that have occurred in the past few years, that we needed to align DOH processes with PhilHealth processes on what are the steps needed before something really becomes a PhilHealth benefit. I'd also like to put it out there that the DOH continues to buy a lot of commodities for mental health, for cancer, for HIV and TB, and even vaccines, no, for kids. And so part of the work now is to have a formal way to share these commodities with private providers kasi they're actually helping, no, the care provision at hindi na rin sila kaya ng public facilities alone. So really, for example, to formalize giving vaccines to some private providers or to all private providers because budgeted naman sila, no? Binibili naman sila ng gobyerno. And the last enabling part is system intelligence. Many of you will actually say, bakit walang ganitong data yung DOH? Bakit wala, no? In fact, COVID-19 is actually the first condition that we have daily reports, no, of cases. And imagine if we actually have more data for more diseases coming in. No? Imagine the type of response or the type of even accountability that we can exact from our leaders. So with that, I just go to the last few slides, which is what can you do? No? What can you do to bridge yourself to primary care or to support primary care work? Very simply, number one is to use our social capital. Any physician, any healthcare worker at this point in time, you would always have the highest social capital in your area. You will be able to accelerate efforts on healthy communities, healthy schools, and workplaces, as mentioned a while ago. Be it as a resource person, be it as a champion, to talk to, say, the local chief executive or the city health officers, for example. Or in the national level, talk to the senators, congress people, when we actually need to pass these legislation. Second is to review pre-service and in-service programs to build the healthcare cadre of the future. And so we're happy to hear from Ma'am Charlotte kanina that APMC is actually already doing this. Third is to work to increase competence and confidence of primary care workers. And that would range from BHWs to even GPs and family med practitioners. So one of my classmates, Brian, for example, who works in Cebu, he's an IDS. One of his work there is really to train or even rounds, no? I-tele-rounds niya yung mga GPs outside of Cebu City in order to help them manage COVID patients. Similar to that, I mean, usually they will actually send their patients to the hospital because they're not confident to treat. But when a specialist is there who has their back, helping them out, they're more likely to actually render those more complicated services, particularly during this time of the pandemic. And then the last would really be to participate in or support efforts to digitize health. No? So support efforts to have EMRs or EHRs in your institution, because increasingly we have to move towards that. The health sector cannot steer itself when it's blind, but at the same time, the data will not be coming all from the DOH. It's all coming from facilities, and facilities need to recognize, or providers need to recognize, that when they collect the data, it's not just for purposes of submitting it to health authorities, but actually for also improvement in their facility or in their population that they're covering. I'd like to end by saying that many of the reforms are difficult and will be difficult, but they have shown to work in many settings and have really good promises for our people. And so we need the reforms, but we need financial resources and actually political will to implement them. And so I end by saying that let's all go out and vote wisely in the coming election, because we will need leaders who will make or enable all of us to make UHC happen for the Filipino people. So I'll end the presentation there, and thank you very much for your kind attention.
Thank you, Dr. Beverly Ho, for sparing us time from your busy schedule just to be with us today. We will now open the floor for questions from our audience. This live forum will be moderated by Dr. Anthony G.H. Cordero and Dr. Vincent Schubert Malbas. Dr. Cordero is the director of the UP Manila Community Health and Development Program, and Dr. Malbas is a medical specialist from the PhilHealth office.
So, good afternoon, everyone.
Good afternoon, everyone. Hi. Okay.
Doc Bev, congratulations on your wonderful presentation. It was very comprehensive, and it actually embodies our theme of bridging science and practice for a healthy Filipino. So good job on that.
Okay. Maraming salamat, Bev. Thank you very much.
We have several questions already that we received from our YouTube and our Zoom channels. thank you to our 1,000 plus audiences that we have here as participants. Thank you for coming to this session. Our first question that we received via the channel is do you have any updates or feedback on the implementation of the universal healthcare in the identified pilot sites? And what were the enabling factors that made it as a success, or challenges that we need to improve on?
Thank you for the question. I think when we go back to the maturity models, at least the 58 first implementation sites, UHC implementation sites, were assessed using those frameworks. And many of the sites are actually in level 1 or level 2 for most of the indicators. Wala pa talaga tayong site na, okay, perfect, level 3 na siya for all of the 10 indicators. But that just goes to show po that every area is actually in a different place, and then actually they have to work on different milestones. But what is important, or what is cross-cutting among those areas, are they actually volunteer, diba, to be part of the sites, no? Hindi sila parang sinelect ng DOH. They actually raised their hand and said they want to do it. And so they also happen to have more assistance coming from development partners, because they're also the ones who are more receptive to try out new things, diba? And so I think with that, I'll just say that we have some of the advanced sites who are more promising than others, but governance and leadership and community ownership plays a very big role. So meron tayong like kunwari sila Jackie, no, sa Agusan, former DTTV, UPMed 2011. They're pretty advanced, no, not really because they have so much resources there, but because they really want to make things happen, or they want things to progress. So yun pa rin, no, may uniqueness yung each area, and leadership and governance plays a very big role.
Okay. Bev, yung isang related question, especially with respect to the pilot sites, is, and I'm sure you've been asked this question a billion times, is ano yung naging epekto ng COVID pandemic in terms of the rollout of the Universal Healthcare Act, both among the pilot sites and for the rest of the country?
Sure, I wouldn't have systematic evidence to answer the question, pero I think in general, no, what we can say is that for some parts, COVID-19 pandemic stalled some of the things we want to do, right? But for most part, actually, it drove, no, what needs to be done. For example, dati, wala talagang may gustong pumansin sa health promotion, di ba? Or sa, say, getting the community to work together, or making sure people are more health literate. But because of the COVID-19 pandemic, you can't wear a mask on behalf of another person, right? You can't do parang it's not a service na ibibigay mo na lang. You need people's effort, no? And so we've seen that LGU suddenly had to invest, no? In actually yung iba nagdagdag ng significantly more BHWs, yung iba mas nagbigay sila ng more allowances for their healthcare workers, because it was needed, because the pandemic showed that it was needed. Second is telemedicine. I mean, we know from National Telehealth Center, it's almost 2 decades, no, that they're really pushing for telemedicine to happen. And for a very long time, the issues were around legal, sino yung magkaka-liability sa pag nag-telemedicine tayo. But during the pandemic, in 2 weeks, no, lumabas yung enabling policies na kailangan na mag-telemedicine. Diba? So parang I think may mga natagalan kasi nahirapan pumasok yung mga tao. Actually, admittedly, no, yung ibang sakit, nag-suffer po talaga. For example, vaccination ng kids. No? We're now at, as of mid-year, 20% fully immunized child rate. Diba? Why? Because all of the healthcare workers have to be diverted to COVID vaccination or to COVID-19 response. So yes, there are some things that suffered, but there are some things that also progressed because the pandemic happened.
So, related question po, Doc Bev, no? So, you mentioned na-exacerbate yung inequalities. Like for one LGU, they are very capable of addressing the health needs of their community, whereas the other LGU sometimes don't have the resources. How does the government address these kind of inequalities?
First, of course, is assistance, di ba? Assistance will be needed if the LGU is not able to handle it. So assistance came in the form of many of our development partners or CSOs who actually supported some of these LGUs. Second is the assistance can be in the form of yun, no? Parang PA or additional staffing, emergency hiring, but it can also come in the form of actual resources, no, whether in cash or in kind. So for some LGUs who didn't have the facility to test, for example, or to buy their test kits or to buy their PPE, so the national government had to step in. Yeah, I think in summary, parang ganun, no? Cash or kind, training, or additional staffing yung mostly kinailangan ng LGUs. Mas konti yung supporting them in planning kasi for once din, no? I mean, Doc Ann, sa dinami ng mga pinupuntahan nating community, typically ang hirap i-bring on board ni mayor or ni governor, diba? Pero ditong COVID, I guess wala nang choice yung mga tao. So they were really on top of the situation. And there was really activation of the local communities, particularly their DRRM communities. So I guess that's also something to be happy or grateful about.
We have also another question from the audience. No? How does the universal healthcare law and the programs encompassing it, how does it address the low health literacy in the grassroots?
So the UHC has a very specific provision on health promotion. No? So it actually talks about, well, my office now, it used to be a small one. And the perspective was really around campaigns. No? Commercial tayo sa TV, ganyan. And the idea that was espoused there follows the Ottawa Charter of Health Promotion. Now it's really community mobilization. It's mix of social marketing, but it's also largely policy and programmatic work. Kaya yung nakita nyo kanina na medyo matagal ako nag-present doon, that's the idea of health promotion now. It's not just campaigns. So that said, no, we have a whole program of work together with DepEd, SHED, DESTA, as well as the private schools. Then we have a whole program of work with communities. No? So kunwari, we're actually giving grants for them to build more bike lanes, for example, or to have healthier carinderias, etc. So yung mas practical na on the ground na kaya nilang gawin as a community. Important din sa atin na hindi lang siya, sabi nga namin kanina, puro curriculum. No? Kasi everyone wants to add something into the curriculum. Wala na talagang magigets yung bata doon. So I think it's related to that also is having not just a bigger office here, no, in the DOH that thinks about and retooling everyone on health promotion, but making sure actually LGUs allocate people for this job. And yung pinupush namin talaga with the amendment of the BHW Act is that the BHWs really become your de facto health promotion officers on the ground, which is really what they're supposed to do. And if you want them to do that, they have to be enabled. No? Meron silang ability to go out around the community to help people. But it's also clearly recognizing, no, it's not just about knowledge, but the environment has to be enabling. So kahit turuan natin lahat na masama yung tobacco, pero pwede naman mag-smoke kung saan-saan, people will still do it. So it's balancing the individual behavior with the environment.
Okay. Maraming salamat, Bev. Related dun sa points mo about yung yung isa mong point kanina na let's vote wisely. Yung isang question from the participants, the universal healthcare as mentioned needs political will. What programs or activities are being undertaken or planned by the Department of Health to strengthen governance for health in order to deepen the understanding of universal healthcare and actually make it work?
Hirap, joke lang.
Okay.
So,
No? Essay yung tanong.
So in the past, we've had and actually we do have still continuing relationships with some NGOs, no, that really espouse good governance. In particular, we can mention ZFF, no, Zwilig Family Foundation, who has a whole portfolio of work on really health governance alone, no, and their theory of change is basta on board ang ating highest local chief executive, a lot of things can move, no. And even if we don't have a formal arrangement already with them, the collaboration still continues. No, they still support a lot of the LCEs. But sa DOH in particular, I think we're really moving towards accountability by publishing data. No, so nag-start na tayo, di ba, with COVID, that I guess local chief executives are really calling out na kung hindi yan yung number ko, hindi yan pareho sa akin. Kasi it really reflects on their ability to manage the disease, no? And in this particular case, COVID. So kung magagawa natin to for all other conditions na ngayon actually very late natin nakukuha yung information, tapos na, no, yung kailangan response bago natin siya na-publish, it's not as effective. So our goal is to keep getting, no, it's the people who actually need to recognize na my leaders are not actually able to do the work. And then of course, there are regular mechanisms, no, kung saan kami nakakapasok, like onboarding ng mga LCEs, may mga meetings with ULAP, but these are more ad hoc, I would say, no. And for us, it's really holding them accountable by their performance. That will be the long-term strategy in getting really the LGUs to perform better.
Yeah, I think may follow-up question tayo from the audience na nagtatanong na some local health units daw are not under DOH but rather from the local government. So na-mention mo naman na ad hoc yung duties ng DOH, like coordinating with ULAP and other local government associations, no? So nasagot na yung question na yun. Okay.
Okay.
Doc, may personal po na question sa audience. Bakit daw po magkaiba ang policy ng bawat LGU regarding sa handling ng COVID-19 patient? Some of the LGU do swabbing, tapos the other LGUs do not do re-swabbing. Parang ganun.
Well, yan yung mga challenges natin with a devolved setup, no? So we issue out the standards, but the enforcement is really difficult, no? So ang latest namin na strategy is really to work with DILG. But in these cases, no, nahirapan din talaga yung DILG because some LGUs are actually more stricter and they consider it as them protecting themselves better or their communities better than the others, no? So wala akong actually masabi dyan except talagang part to ng devolved setup and mahirap. Hindi rin talaga namin sure, no, paano to i-encounter, especially i-counter especially during this pandemic. Kasi may reason naman sila na gusto nilang maging stricter or safer.
Tapos parang connected din sa theme ng talk, yung bridging the specialist with the primary care, may mga questions kasi na parang kailangan na bang dumaan lahat sa primary care provider before magpuntang specialist, tapos yung primary care provider ba paano ba siya masasama dun sa sinasabi ng batas na service delivery network, tapos yung service delivery network, paano ba yun binubuo? May roadmap ba doon? So parang in relation to the theme of bridging the Doc Bev?
Thank you, sir. So, syempre, hindi naman natin pwedeng ipatupad yung bawal ka nang dumaan sa primary care provider mo kung, number one, you actually don't have enough primary care providers, di ba? So, kaya sinasabi ko rin nga po kanina in the presentation, this will really be a generational shift. No? We will have to work on this, and some systems, some local systems may actually do it faster than the others. Because if you already have the enablers that I mentioned kanina, then you can actually proceed with integrating them, no, or putting them together. But if you don't have the individual ingredients, it's going to be hard. So, for example, we know, no, that some of the more progressive LGUs would probably include, or provinces sa Aklan, no, or sa Bataan. So, meron na silang good information system. May mapa na sila ng lahat ng facilities. They included the private sector in their mapping. So, they know how else, no, they will add on to yung mga kulang. So, if wala nung mga basic na yon, rest assured, no, we also wouldn't be forcing our way through things. No? And then, I think recently what's also being discussed is sandbox type of policies, meaning there will be more and more experimentation in certain sites without making it national policy yet, and see whether it works, no, before you actually adopt it as national policy. So, wag po kayong matakot. Hindi po to lahat biglaan, no. There's actually a step-by-step process, and it also means that each province-wide or city-wide system will have to take their time, actually, and they can find their route, no. What has been set is the destination, not the process, di ba? Hindi yung step 1 hanggang step 100. Hindi naman po. No? So you actually have flexibility. So doon po sa mga lugar na, kunwari, I met sila Sir Don Isla, no, sa area nila. Parang medyo cohesive, no, yung provider networks nila. Hindi sila formal, pero magkakakilala silang lahat in that area. So it actually makes a level of integration easier compared to, say, here in Metro Manila, diba? Where so many people are here and or so many providers are here, and we actually all don't know each other. So the context is actually going to be important, and it will determine speed, style of the integration. And that's something that we don't think we should prescribe po.
May follow-up question kami regarding the providers, since karamihan ng audience natin ay healthcare providers. No? So is there a specific specialty na masasabi nating specialists in primary care? And kasama ba yun ng mga nurses, medical technologists, and everyone?
Yes, no, I think yun yung unang-unang kailangan klaro sa ating lahat. We're not talking about physicians alone. We're actually talking about a team, no? So yung team natin ay collaboration at many levels. So the primary care team will actually be a mix of not multi-specialty, no, but multi-professions group. So that would include your BHWs, your midwives, your nurses, and hindi rin siya dapat may bawat isa, no? Kasi depende din talaga yun dun sa lugar. And that's why we're also saying that people have to be connected, because there might be some areas wherein they only probably will have a nurse and a midwife, but you will actually be able to say they're part of a primary care team because they actually can refer to, say, the MHO of the kabilang munisipyo, no? And they can refer cases na hindi nila masyadong alam i-address or nahihirapan sila i-address. So there are many ways to look at it. Pero ang point natin is, let's not be limited by the traditional definitions of roles. And increasingly, this will trigger a lot more task shifting and sharing. And so even among specialists, so kunwari, kulang talaga tayo ng certain anesthesiologists in the entire country. talagang ma-open ulit no yung mga discussions on can other cadres perform certain tasks no related to this in GIDA areas kasi hindi naman pupunta yung certain specialists doon. So lahat po to are going to be opened on the table, and syempre yung may level of pag-aaral din na mangyari and preparation as what Ma'am Charlotte has mentioned. So it's going to be gradual, but the reason why I think we're having all of these discussions is to have the government cannot think of everything. All of us will have to pitch in, and maybe for some other specialties, they can contribute a different model versus other specialties. So parang it might not be uniform then even across yung pag-task shift at pag-task share. Over, sir.
Okay. Over and out ba? Hindi pa yata. Yung isang question, Bev, kasi di ba, especially yung binabanggit mo kaninang province-wide system, may mga ibang municipal mayors na medyo may mga misgivings doon. So, paano yun na-address, Bev?
Well, sir, kasi kung naman sa initial stages, marami pang kailangan gawin before the actual full integration happens, so which is full sharing of money. We always talk about it as progress. For example, when we talk about the province-wide system, we want na, or ayaw na natin mangyari yung mga dati na magkakatabing munisipyo, meron lahat silang X-ray or CT scan. Tapos yung lahat nung nandito sa kabila, lahat wala sila, di ba? So we wanted parang a fair, no, or efficient planning. But that efficient planning will not happen when hindi tayo nagkakakitaan kung how much we have, ano yung mga plano natin, no? So I guess the first step is really much more benign, which is let's show each other what we have, what our plans are, and let's plan together. I think that's pretty harmless, no, or very low risk. And eventually, when trust is built, because collaboration cannot happen without trust. When trust is built, and when the people, ito ulit papasok, no? When the people are actually the ones demanding for efficient services, which will require integration in the system, I think it will follow, no? That the local chief executives will understand that they will actually have to do it. So ako, yun po, no? May step by step, gradual yan, trust building. Pero importante talaga to bring in the people. Because when the people have already started experiencing good services, mahirap yun i-withdraw sa kanila. Diba? Hahanapin nila yun. At talagang magtutulungan yung mga LGUs to deliver that because it is good politics also for them.
Okay. At Doc Bev, parang nasagot mo rin dun yung isa mong question na sino ba yung iboboto natin. We should vote for officials na hindi natatakot sa isang empowered citizenry, no? Vincent,
meron. We are receiving a lot of questions. They keep on coming, no? But in the interest of time, we need to wrap up our discussion. So, Doc Bev, do you have any take-home message for all our audience, especially the health workers in attendance?
I thank you. First of all, maraming salamat po ulit for this opportunity to exchange ideas. I always learn a lot from sessions like this. Second is, no one has a monopoly of all the great ideas. So ako sa offices that I'm with, we're happy to collaborate, to discuss, and even to partner. And that is actually the bread and butter of health promotion, particularly sa amin. Partnership, no? Because we need to have the energy spread out across the entire country to actually make things happen. And not all of the energy can come from a single entity, no? So yun po, please feel free to reach out if you want to work together, etc. And then finally, I think it's we all need to contribute to make this happen. It's not going to be something that the government legislates and it will happen already. So for many countries, they've took 2, 3 decades to build their primary healthcare system before it actually started significantly benefiting their people. I think what we're sure of from the evidence na meron tayo is hindi pwedeng skip na ulit natin yung primary healthcare. Parang for many years, it was easier, to build hospitals, train more specialists. I guess from a system standpoint, but I don't think at this point we can parang turn a blind eye towards not building the primary healthcare system. So I do hope that with the many examples put forward, and I'm sure in your many discussions and experiences, alam niyo po na marami kayong pwedeng ma-contribute to making primary healthcare a reality. So please just make sure na you put that you actually are able to be in those circles, because we know that it's also very, very rewarding and fulfilling for many of the specialists as well, or the non-primary care practitioner. So yun lang po, and hopefully we create a groundswell to actually make it happen na hindi na rin siya talaga kayang hindi pansinin ng mga leaders natin. So yun lang po, maraming salamat.
Thank you once again, Dr. Ho, and to our moderators for a very enlightening discussion on universal healthcare. We would like to award the Certificate of Appreciation to Dr. Beverly Ho for her invaluable contribution as the keynote speaker of the UP College of Medicine Grand Scientific Symposium given this 21st day of September 2021. Signed by Dr. Maria Assumpta Cecilia Serrano, President of UPMAS Davao, Dr. Teresa Luisa Cruz, Director of Postgraduate Institute of Medicine, Dr. Charlotte Chong, Professor and Dean of UP College of Medicine, and Dr. Lara Teresa Aleta, President of UP Medical Alumni Society. We would also like to award the Certificate of Recognition to Dr. Anthony Cordero and Dr. Vincent Schubert Malbas for their contribution as moderators for the first focus session on universal health care, given this 21st day of September 2021. Thank you, doctors.
Okay.
We will be having a 2-minute break before we proceed to the next focus session. Please stay tuned. Welcome back to the UP College of Medicine Grand Scientific Symposium. For the second session, we will be discussing the very pressing topic of COVID updates and forecast. The session chair is Dr. Catherine Roa, an adult ID specialist and the president of the Philippine College of Physicians, Southern Mindanao chapter. The co-chair for this session is Dr. Joanne Jajuri Lobo, chair of the Department of Pediatrics and head of the Pediatric ID section in the Southern Philippines Medical Center.
Good day, everyone, and welcome to the first pandemic of our lifetime. Who would have thought that we would find ourselves in this situation? And yet, here we are, experiencing the wrath of SARS-CoV-2 and COVID-19 in different situations and in different settings. For this afternoon, we will be listening to three speakers. The first lecturer will talk about SARS-CoV-2 immunology, as well as the different variants and diagnosis. The second speaker will talk about infection prevention and control in the hospital and even outside the hospital in the community. And also, she will touch on the vaccination program and also the different vaccines that we currently have. And the last speaker will talk about treatment, including how to deal with the complications of COVID. So welcome to this session of COVID-19 lectures.
Our first speaker is an intermediate program graduate of UPCM Class 1991. Straight from his graduation in UPCM, he trained in internal medicine and subsequently in infectious diseases in the State University of New York and Brooklyn from 1992 to 1997. He is currently in private practice as an infectious disease specialist in Santa Barbara and Community Health Center of Central Coast. Currently, he is a principal investigator of an active phase 2 trial on an investigational drug for mild to moderate COVID-19 patients. Please help me welcome our esteemed speaker, Dr. Franco A. Felizarda.
Thank you for the kind introduction, Dr. Mata. Good afternoon to all of you. Magandang hapon po sa inyong lahat. Thank you for inviting me to the UPCM Grand Scientific Symposium 2021. I'm very excited to start with the COVID-19 basics and updates regarding virology and immunology. This will be the first part. The second part will be on diagnostics. I have about 25 slides and we'll need about 20 minutes, but don't worry, the second part will be shorter, less than 10 minutes. So let's start with an interesting study ranking the risk of animal to human spillover of newly discovered viruses. They rank 887 viruses, and they have multiple experts from different countries assessing about 31 risk factors. The maximum score was 155, and as you can see here, SARS-CoV-2 ranked second out of 887 viruses, and SIV, which resulted in the deadly HIV epidemic, is ranked 8. So based on this, the two worst epidemics of the modern era are predictable. This one is a report from Johns Hopkins Bloomberg School of Public Health Center for Health Security. This was published in May of 2019. So this is pre-COVID. And they look at the common characteristics of a potential GCBR, or global catastrophic biological risk level pandemic pathogen. And they have 5 findings. First, its mode of transmission will most likely be respiratory. So that's an easy prediction. Number 2, it will be contagious during the incubation period prior to symptom development, which makes sense because if you have a virus that's contagious only during the symptomatic stage, you can easily stop it by isolating the patient during the symptomatic stage. Number 3, immunologically naive persons, the whole population should not have any existing immunity against the virus. So you should have a novel virus. Number 4, this one is quite counterintuitive. A low but significant infection fatality rate, just like the 1918 influenza virus, which is about 2.5% infection fatality rate. These two together substantially increase disease spread and infection. This makes sense because if you have a virus that has a very high IFR, infection fatality rate, let's say about 50%, it will probably kill most of the hosts before it spreads. And number 5, they predicted that it will be a respiratory-borne RNA virus, just like influenza, because they have high mutation rates. And guess what? All these 5 characteristics are characteristics of COVID-19. So let's start with the virology. SARS-CoV is a beta coronavirus. It's lumped together with SARS-CoV and MERS-CoV. MERS is Middle East Respiratory Syndrome. And take note that the 4 other common cold coronaviruses are either alpha or beta. This one is just showing you that they use different receptors, the coronaviruses, but the most common receptor is ACE2, which is angiotensin converting enzyme 2. These are the virus host interactions of the coronaviruses. The primary hosts are usually bats, and there's usually an intermediate host. For SARS-CoV-2, the primary host is probably a bat. There's probably a intermediate host, and that could be the pangolin. There's also transmission to cats and dogs and to minks. There's also some data that there's a transmission from mink to humans. So this could also be a intermediate host. This one is the SARS-CoV-2 virus. You have the nucleoprotein or nucleocapsid that surrounds the viral RNA. You have the envelope and matrix proteins, and then you have the famous spike protein, which has the receptor binding domain that binds with the ACE2. The diameter of the virus is about 100 nanometers or 100 micrometers or 100 microns. This is the SARS-CoV-2 genome. And this one consists of about 30,000 nucleotides representing up to 15 open reading frames producing 27 proteins. And as you can see here, the S1 part of the spike protein has the RBD or receptor binding domain. This is the receptor binding domain that binds to the ACE2 receptor. Now, most of the mutations occur in the RBD or receptor binding domain region and after that. So for example, for the Delta variant, the mutations, one example mutation is at position 614, which is actually the first mutation that increased the transmission of the original Wuhan virus. There's also mutations at position 452, which decrease the neutralization, and there's a mutation at position 681 that increased the transmission too. And all of this occur in the RBD or after that. So these are the variants of concern. You have alpha, which was first detected in the United Kingdom, beta from South Africa, gamma from Brazil, and Delta from India. Mechanism of entry, we already mentioned this, the viral binding to the ACE2 receptor. There's actually a second co-receptor, which is actually a protease TMPRSS2, transmembrane serine protease 2. It cleaves the area between S1 and S2 right about here. And after cleavage, it initiates the formation of the host and viral fusion. The RDRP, the RNA-dependent RNA polymerase, is also important because it makes the genomic RNA. This is the major target of antivirals. As we all know, the viral entry is into the upper respiratory tract because they have a high number of ACE receptors, then it infects the lower respiratory tract and then disseminates to other body organs, especially the kidney and heart, because they have high levels of ACE receptors. 90 to 95% of cases get mild to moderate symptoms, and 5 to 10% of cases develop severe symptoms. And an additional probably 5 to 10% will develop long COVID or chronic symptoms. Let's switch now to immunology. We now know that SARS-CoV-2 is effective at avoiding or delaying triggering intracellular innate immune responses, which is interferon-based. That's why there's some studies on the use of interferon in early treatment. Without those responses, the virus initially replicates unabated, and the adaptive immune responses are not primed until the innate immune alarms occur. So this is almost like a fire alarm. There's a delay in the fire alarm. So in most respiratory viruses, you have this early innate response. In an average COVID-19 infection, you have this delayed response. Thereafter, you have an increase in viral load, but this is taken care of quickly by the adaptive immunity, which includes the T cells. Now, in severe COVID-19 infection, you have this absence of innate immune response in the initial stage, and you almost have this an absence of adaptive immunity that includes the T cells. So the immune system tries to fill the vacuum left by an ineffective T cell response by an ever-expanding innate immune response, and this results in excessive lung immunopathology. So here in the late stage, you have this hyperinflammation due to delayed and excessive innate immune response. This is similar to the cytokine storm, and this is the cascade. This is the basis for giving tocilizumab, which is an anti-interleukin-6 receptor antibody, JAK inhibitors like baricitinib, and of course, glucocorticoids. Long-term immunity, we know that after extrafollicular response, we have the germinal response that has long-lived plasma cells, and this lasts for several months. Then you have the memory B cells that last for several years. We now have data that 95% of infected individuals retain immune memory at 6 months after infection. So natural infection could last several years. Burden of disease. This is the COVID-19 pandemic's true toll. This is according to The Economist, which updates their numbers every day. On September 4, the official global COVID-19 deaths, or the reported deaths, is about 4.6 million, but the estimated global excess deaths is 15 million. That's more than 3 times the reported deaths. And the 95% confidence interval is from 9 million to 18 million. That's 2 to 4 times the reported deaths. And the reason for this is because undercounting is due to the low testing capacity of most countries. For the Philippines, on September 4, the reported deaths is 34,000, but the estimated excess deaths is 70 to 220,000, a mean of 120,000. That's about 3 to 4 times the reported deaths. And the implied infections is 24%. So that means more than 25 Filipinos already infected, and that's more than 10 times the reported cases, which is expected because even in the United States, there's underreporting of up to 4 times for cases. This is the age-specific mortality patterns for SARS-CoV-2. Now, note that about 90% of mortality can be explained by age alone. So for example, for the 80-year-old, the mortality, the infection fatality rate is about 10%. For 60, it's about 1%. For 40, about 0.1%. 20 is 0.01%. And for 10 years old, it's 0.001%. So this is logarithmic, not linear. And there's an increase in decline in children and adolescents and some young adults. And then there's increase in infants. And this is quite similar to the Gompertz law of mortality, which is a logarithmic increase in the mortality. If this is true, then essentially COVID-19 doubles the overall mortality rate. Now, remember, there's a big difference in terms of absolute percentages. So it doubles every 7 years, and if you have a gap of 70 years, the difference will be 1,000 times. So for example, a 90-year-old will have 10% infection mortality rate, and a 20-year-old, which is 70-year gap, will have a 0.01% mortality rate. That's 1,000 times lower than the 90-year-old. This one is a busy slide, but I just want to share you another observation, which is the infection fatality rates of countries and regions is similar to the 2019 crude death rate. Note that in countries or regions, there's two important factors for mortality. One is, of course, the age, and second is the health system capacity. So if you're a poor country, so in lower income countries, coincidentally, they have a younger population, and so their mid-age is lower. So their infection fatality rate is much lower compared to high-income countries. So 1.06% versus 0.22%. However, if you adjust this for health system capacity, this should increase. For example, in sub-Saharan Africa, the IFR is 0.22%, but if you adjust it for health system capacity, it goes up to 0.69%, which is about 7 per thousand. And that's actually quite similar to the crude death rate in 2019 for sub-Saharan Africa, which is 8.5. For high-income countries, it's 10.6, which is similar to the 8.9 crude death rate in 2019. The overall global IFR is about 7 to 7.5, which is very similar to the world crude death rate in 2019. So this is just an observation, maybe a useful observation so that we can compare countries objectively. Epidemiology. So these are the lessons learned in 2020. One, we already mentioned this, pre-symptomatic transmission plays an important role in community spread. Number two, 10 to 20% of individuals may be responsible for 80% of the transmission. So there's a low dispersion coefficient, which is equivalent to having frequent super spreader events. Number three, short-range aerosol transmission is an important route of spread, and long-range transmission can occur in closed, poorly ventilated spaces. So this is one of the recipe for a super spreader event. There's four. One is the indoors, or especially poorly ventilated rooms. Number two, crowding with random people. Number three, unvaccinated. Number four, maskless. So if you have those four factors, you probably will have a super spreader event. If you only have 2 out of 4, the chance of super spreading is much lower, even with the Delta variant. So for example, if you're vaccinated and you have a mask, the chance of a super spreader event is very low. Even if you're not vaccinated, and even if you don't have a mask and it's outdoors and there's no crowding with random people, the chance of super spreader event is also low. Droplet and airborne transmission of SARS-CoV-2. This is quite a busy slide, but the most important thing here to remember is they changed the cutoff from 5 microns to 100 microns. So remember, the virus is 100 nanometers or 0.1 micrometer or 0.1 microns. So if it's more than 100 micrometer, it's called a droplet, and it can travel less than 1 meter and fall to the ground in under 5 seconds. If it's 100 or less, it's called an aerosol, and it can travel within and beyond 1 meter and can float in the air for hours. Basic reproduction number. This is just the number of patients that will be infected during the infectious disease period. So the more contagious, the higher the basic reproduction number. So for example, for the original Wuhan virus, the basic reproduction number is 2.5 persons during the infectious period. The version that caused Europe's first wave, the one with the mutation at the 614 position, is 3. The alpha that first detected in Great Britain is 4 to 5. Delta, first detected in India, is 5 to 8. There's actually some data that it might be up to 9.5. So that's almost like chickenpox, which is 10. Mumps is 12. Measles is 18. Remember, this is exponential. This is not linear. So for example, if you have a basic reproduction number of 5 after 10 generations, it will become 1 million, but 8 will become 1 billion after 10 generations. That's 1,000 times more than the 5. Herd immunity, the equation is quite simple. It's 1 minus 1 over the basic reproduction number. So for Delta with 5 to 9.5, the herd immunity will be 80 to 90%. This is the level of immunity that will stop the spread of the virus, even if there's no social distancing or masks. Now, of course, you can achieve this level with natural immunity, but the safer way would be vaccination. In reality, though, it will be a combination of natural infection and vaccination. In some individuals, it will be hybrid immunity, meaning it can either be infection plus vaccination or vaccination plus infection. Now, the last 3 slides are just pointers how to read the DOH numbers. So, for example, in August 17, there were 10,000 cases, 38,000 were tested, 22% tested positive, 71% of the ICU beds were utilized. In September 6, it went up to 22,000. The 73,000 were tested, 29% were positive, and 76% of the ICU beds utilized. So we're going to look at the risk levels and the key metrics. So you will have the low, medium, high, very high, and severe risk. So for daily new cases, this is usually the average of 7 days per 100,000 people. So here you have 10,000 per 100 million. It's really 110 million for the whole Philippine population. That's really 10 per 100K, and this one is 22 per 100K. And if you look at it, 10 is considered medium risk, and 22 is considered high risk. But now remember, this risk levels is designed for the United States, which has a much higher testing capacity, which is 10 times higher than the Philippines. So 22 might actually be more of very high risk. Positive test rate, it was 22 going up to 29%. That means inadequate testing. But if this is falsely high, if the testing increased, this should go down, but instead it actually went up. So it means it's probably true that there's a high risk of transmission. Number 3 is the ICU capacity used. It was 71 to 76%, so it looks like a medium risk. Now remember, this is a lagging indicator. So this is one of the last ones to go up. The deaths will be up, will be the last one to go up. So, if you get infected, you get symptoms, then you have hospitalized, then you go to ICU, and then you either die or recover. So it's one of the last ones to go up. So it means this will increase probably to high risk transmission, because this is a lagging indicator. The infection rate is the effective reproduction number. This is not the basic reproduction number, which is without social distancing or masks. So if the effective reproduction number or infection rate is over 1.4, COVID will increase exponentially. If it's less than 0.9, COVID will decrease. The only problem with the effective reproduction number is you need at least 2 weeks of data to make it more accurate. So, and if you wait 2 weeks, it will become a lagging indicator. So it will be too late. So I will consider a effective reproduction number based only with 1 week of data, only in conjunction with daily new cases and positive test rate. Thank you. Magandang hapon po muli. This is part 2 of my talk on diagnosis and testing. I will concentrate more on testing rather than clinical diagnosis. I have about 15 slides, so hopefully we can finish this in 15 minutes. Before we discuss testing, let me just review some of the epidemiology, virology, and immunology that was not discussed in the first part, but are relevant for diagnosis and testing. So let's start with the epidemiology. These are the periods of the COVID-19 illness. The incubation period is the time from exposure to onset of symptoms, usually 2 to 14 days, but the median number of days is 5 to 6 days. And the Delta variant is shorter by 1 to 2 days. The infectious period is the time interval during which a host is contagious, up to 10 days in mild to moderate infection. This could be longer for the Delta variant, up to 20 days in severe disease, more than 20 days for immunocompromised individuals. If the latent period is shorter than the incubation period, then you have this stage of a pre-symptomatic transmission. Serial interval is the time period between the development of symptoms with the primary and the secondary cases. Pre-Delta, it's about 4 to 5 days, but with the Delta variant, it's most likely less than 4 days. So together with the pre-symptomatic transmission, this probably increased the transmissibility of the Delta variant. Virology, this study showing that the Delta variant produces much higher viral loads compared with the other variants. This probably explains the increased transmissibility of the Delta variant. This is the red is Delta, yellow is alpha, blue is beta, and green is wild type. And the CT value is the cycle threshold. And in general, the higher the CT value, the lower the viral load. The lower the CT value, the higher the viral load. And a difference of 3.3 in the CT value corresponds to a 10-fold difference of the viral load. And a difference of 10 in the CT value corresponds to a 1,000-fold difference in the viral load. So based on this, the Delta variant viral load is at least 10 times higher than that of alpha and 1,000 times higher than that of the wild type. This is another study showing that the Delta variant produces comparable viral loads between vaccinated and unvaccinated. So red is unvaccinated and green is vaccine breakthrough individuals. And as you can see here, it's comparable only in the first 4 to 5 days, but after the first 4 to 5 days, there's a dramatic drop in the viral load for vaccine breakthrough individuals. So this might explain the decrease in efficacy, vaccine efficacy versus infection, but it should explain the great protection versus severe disease, including hospitalizations and deaths. Immunology, this is the estimated variation over time in diagnostic tests. This is the pre-symptomatic stage. The red is the virus isolation for respiratory tract, which corresponds with the infectiousness. And we already mentioned this in the previous slide that for mild to moderate, it's usually less than 10 days. Blue is the nasopharyngeal swab PCR, can be detected a few days before onset of symptoms, and it decreases gradually. And the maximal duration of RNA detectability is up to 3 months for upper respiratory tract infections after onset of symptoms. The IgM is the purple line, green is IgG. Usually they start at the same time after the infectious disease period, but the IgG lasts longer. This is the sensitivity of diagnostic tests over time. As you can see here, the PCR sensitivity decreases with time, but the immunoglobulin sensitivity increases over time. The sensitivity for PCR is more than 90% in the first 4 days. And for the immunoglobulin, the sensitivity approaches 100% at about 3 weeks, and it gradually decreases after 4 weeks. Diagnosis, these are the symptoms compatible with COVID-19. The most important thing to remember here is shortness of breath and new loss of taste or smell. If you have both of this increases the pre-test probability, and we'll discuss that later. Diagnostic tests for SARS-CoV-2, you have the RT-PCR test, which is a reverse transcription polymerase chain reaction, highly specific, standard of care, multiple targets. Then you have antigen tests, which are cheaper and faster, but lower sensitivity than a PCR. Only one target, the nucleocapsid protein. and antibody tests, which are not as specific as the PCR, and usually three targets: the spike protein, the nucleocapsid protein, or the receptor binding domain of the spike protein. So let's go to RT-PCR testing. As we mentioned, there are multiple targets, and you have, including the RNA polymerase, the spike envelope, and the nucleocapsid portions of the gene. And interestingly, the alpha variant has a deletion at amino acid 69 to 70, which impact the ability to detect the S gene that encodes the spike protein. So, but most PCR tests will still detect the SARS-CoV RNA even if they fail to detect the mutated S gene, because it has multiple gene targets. So the S gene target failure was actually used as a marker for the alpha variant by the British. This is the RT-PCR positivity by specimens. As you can see here, it's highest for bronchoalveolar specimens, but this is not practical. Acceptable for nasal swabs and sputum, but quite low for pharyngeal swabs and stool. This is showing you the pre and post-test probabilities based on RT-PCR with a 70% sensitivity and 95% specificity. So for example, let's say you have a pre-test probability of 50%. So you don't really know if the patient has COVID. Let's say the patient has fever and cough, but nothing else. If you have a negative test, it decreases the probability. So that's a post-test probability to 25%. But if you have a pre-test probability that's quite high, let's say 90%, let's say the patient has shortness of breath, loss of smell or taste, and had exposure to a confirmed case, if the test is negative, it only decreases the post-test probability to 75%. And if you repeat it again, let's say 75%, a negative test will result in a 50% post-test probability. So you're still not sure. So if you have a patient with a high pre-test probability and a negative test, you can empirically treat the patient. Now, if you have a 50% pre-test probability and the test is positive, the post-test probability increases to 90% because it's more specific than sensitive. Practical strategies for RT-PCR and antigen testing. I have 10 pointers here. So for symptomatic patients, one, test early as possible after the onset of symptoms. Remember, the sensitivity is more than 90% in the first 4 days. Standard or rapid, which provides results within 1 hour, RT-PCR is preferred. Antigen tests, which should be used within 7 days of symptom onset, because if you use it after 7 days, the sensitivity decreases. And rapid isothermal amplification assays may also be used, but may have lower sensitivity. Number 4, negative antigen test should be confirmed with standard RT-PCR if suspicion for COVID-19 remains moderate to high. If the repeat RT-PCR test, repeat the RT-PCR test, if the initial RT-PCR test is negative, if there's a high clinical suspicion, and we already discussed this scenario a few slides ago. Number 6, nasopharyngeal swab is considered gold standard, but you can also use anterior nasal, mid-turbinate, saliva, but not oropharyngeal or stool. We discussed this a few slides ago also. Number 7, so if the patient is asymptomatic but has exposure, you have to test the patient on day 5 to 7, but with Delta, you probably have to test them earlier, day 3 to 5. So the ideal is 5th day. Number 8, positive antigen test should be confirmed with standard RT-PCR if there's low clinical suspicion. This is the opposite of the negative antigen test with high clinical suspicion, and you have to confirm it with standard RT-PCR. So positive antigen tests with low clinical suspicion, you have to confirm it. Next one is post-recent confirmed infection. So you have 2 consecutive infections. So RT-PCR testing if with symptomatic second episode and at least 45 days after first detection of the RNA. Or if they are asymptomatic but had exposure, at least 90 days after first detection of RNA. The reason for this is it's very rare to get a reinfection in the first 90 days after infection. And also, you can have a positive PCR test for at least, for up to 3 months. And even if the patient's recovered, and and remember, even if the PCR test is positive, it doesn't mean you're infectious. Number 10, evaluation of the CT value may be considered in selected cases, but there are major limitations to this approach. Why? This one is showing you CT values versus viral load of a random group of 8 assays. And as you can see here, all the slope of the 8 assays are comparable. So if there's a decrease in the CT value by 10, there's also a decrease in the viral load by 1,000-fold. So it's pretty consistent with all the assays. The problem is the intercept are different. So for example, if you have a viral load of 10,000, the CT value in one assay will be 20, and in another assay, it will be 35. Okay, so the CT values are not comparable from one assay to another. When comparing data from different studies, CT values should be considered as trends rather than absolute values. Antibody testing, I have 5 pointers here. So number 1, serologic testing is not a replacement for virologic testing and should not be used to establish the presence or absence of acute infection. Number 2, antibody testing may be useful to support the diagnosis of COVID-19 if the positive antibody test is at least 7 days. Now, preferably 3 to 4 weeks. Remember, the sensitivity is highest after 3 weeks, and then it decreases gradually after 4 weeks. Ideally, you want a previous negative antibody test and a negative viral test, so you can document the seroconversion, but it's quite rare to get a previous negative test. Number 3, a positive antibody test can help support the diagnosis of MIS-C, or multisystem inflammatory syndrome, in children, or long COVID. Number 4, serologic assays that detect IgG and total antibodies have higher specificity. So we prefer IgG or total antibodies. You don't want to use IgM because of a high false positive rate. Number 5, there are 5 parts. 5A, serologic testing can be used to help differentiate natural infection from vaccination, except for inactivated vaccines. So if you, in a person never vaccinated, testing positive for antibody against, let's say, either nucleocapsid or spike proteins will indicate prior natural infection. In a vaccinated person using mRNA or vector vaccine, so mRNA will be either Moderna or Pfizer, vector will be could be AZ, J&J, or Sputnik. Testing positive for antibody against the vaccine target, such as the S protein, the spike protein, and negative for other antigens, suggests that they have produced vaccine-induced antibody and they were never infected with SARS-CoV-2. In vaccinated, the same person, testing positive for any antibody other than the vaccine-induced antibody, so such as the nucleocapsid protein, indicates resolving or resolved infection that could have occurred before or after vaccination. So this is what we call hybrid immunity. This is actually the best immunity when you have a infection and then vaccination, or vaccination then infection. 5D, in a vaccinated person, but vaccinated with inactivated vaccines like Sinovac, testing positive for the antibody versus either the nucleocapsid or spike protein suggests that they have produced vaccine-induced antibody and or a prior natural infection. So you really cannot differentiate between prior infection and vaccination if you had Sinovac. And last one, remember, some organizations like the National Institute of Health recommends against the use of serologic testing to determine natural or vaccine-induced immunity. Why? Because we still don't know the level of the antibody that would protect us against infection or would protect us against severe disease, which includes hospitalization and deaths. Thank you.
Thank you, Dr. Felizarta. Our second speaker is the valedictorian of UPCM class 1989, and a graduate of the Intermed program. Soon after her internship in UPPGH, she specialized in internal medicine at St. Francis Hospital in Evanston, Illinois, prior to her subspecialty training in infectious diseases at the Medical Center of Loyola University. She is based in Arizona as an assistant professor of medicine at Mayo Clinic College of Medicine and Science. She is currently the president of the Arizona Infectious Disease Society. In research, she has made significant contributions on COVID-19 monoclonal antibodies and a COVID-19 antiviral combination drug studies. Let us welcome Dr. Maria Teresa A. Sevilla.
Thank you, Dr. Mata, for that introduction. And I would like to thank the organizers for inviting me to speak at the symposium. Disclosures, I have no financial disclosures, but I would like to say that the views expressed are my own and not that of Mayo Clinic, and that this was recorded on August 15 at 1700 here Pacific time. So I was given the task to discuss these topics, including infection control, vaccine, rationale, and real-world effectiveness, and investigational pre- and post-exposure prophylaxis, as well as something about the Mayo Clinic COVID-19 experience. So let's start with infection prevention and control. So SARS coronavirus 2 is transmitted predominantly by respiratory aerosols, and much minor way of transmission is through fomites. And so the way to prevent the transmission is not to share air with somebody who's carrying the infection, and minor is not to touch it. So how do we do that? There's a lot of talk about the personal protective equipment, or PPE, and shown here are infographics from the CDC on the left, and then from the World Health Organization on the right. And for somebody who's taking care of a COVID-19 patient, the ideal PPE would include an N95 or higher respirator, wearing a face shield or goggles, wearing an isolation gown, and a pair of clean non-sterile gloves. If N95 masks or respirators are not available, one can use a face mask. But boots and coverall suits are not required for this infection. So looking at the hierarchy of controls, and this is taken from occupational health, or occupational safety rather, looking at most effective from the top to least effective at the bottom, you can see that PPE is down here at the bottom. So it's really the last barrier for a person not to get infected with an infection. And that is the least effective. So we want to try and get to the more effective ones, like elimination, which is removing the hazard, which is difficult with a virus, apart perhaps from using a vaccine. We can't substitute or replace the hazard, so we'll skip that. And then engineering controls are really important. So this would isolate people from the hazard, or the virus in this case, by using physical barriers, using sanitizers, or improving ventilation. And then next down is changing the way people work by making them more distant from each other, or staggering schedules so that people are not working at the same time or working from home. And then lastly, like I said, least effective would be using PPE. So as far as some of those controls, one is of course patient placement, immediately isolating somebody who's suspected or a confirmed case of COVID-19. And they should be separating suspected and confirmed patients, because some of those suspected will not be infected. Ideally, if available, single patient rooms should be used, because there has been transmission with roommates. And then maintain at least 1 meter distance between patients, and don't put more than one patient in a hospital bed if at all possible. As far as managing the environment, one should limit movement of patients within the facility. If a patient needs to be moved, that should be planned ahead, and appropriate PPE should be donned by everybody who will be in direct contact with the patient. Regular environmental cleaning is very important, because like we said, it could be transmitted by fomites, and this would be a way not to touch the virus. More importantly is adequate ventilation. If negative pressure is available, a negative pressure isolation room would be ideal. If that is not available, then just increase this air circulation in the room by opening doors and windows. Other, not less important measures, of course, are hand hygiene, and then early recognition and diagnosis. So a lot of institutions would do symptom screening of people. However, that is limited by the fact that some patients are infected with COVID-19 without symptoms. And so some would also do testing of asymptomatic patients. And so a lot of hospitals would test patients on admission and then on some regular basis to catch patients who may be asymptomatic but infected. And then, of course, testing the symptomatic individuals. And then contact tracing to see and catch patients who might be infected early on, even before they get infected. And then visitor management. Some hospitals don't allow visitors when there is an outbreak or a surge ongoing. So as far as environmental risk factors, which apply both in the hospital or healthcare facilities, as well as the community, these are the important factors to look at. Location, so outdoors or open air spaces are safer than enclosed spaces because aerosols would be dispersed a lot faster. Proximity, so farther away from others is safer than being close together, ideally a meter or more in distance. And then the time being with somebody, shorter time periods with others are safer, and 15 minutes in a 24-hour time period is designated as a risk factor for getting COVID. Now, if somebody was to stay indoors, masking is recommended, and that should be at least 2 or more layers of a fabric, should cover the nose and mouth and then fit snugly against the side of the face and not have gaps, including above the nose. So using a nose wire to fit that better would be ideal. So at the home, if there is somebody who has COVID-19 inside the home, ideally there would be only one household member designated to be the caregiver, and that would be somebody who has the fewest or no risk factors to have severe COVID-19 infection, if at all possible. And the COVID infected patient should be in a separate room or isolated space. And also if there is a bathroom that could be dedicated for that person, that would be ideal. Opening windows to allow air circulation is advised. And then again, being less or more than a meter away from the infected individual. Everyone should wear a medical mask when in the same room with the COVID-19 infected person. And of course, cleaning hands frequently and cleaning and disinfecting surfaces, particularly those that have been touched by the infected individual, should be done frequently. And using separate dishes, cups, and eating utensils are also advised. So what do we do after exposure to somebody who is infected? This is the current CDC guidance dated July 29, 2021, with an exposure being defined as a close contact within 6 feet or 1 meter for a cumulative total of 15 minutes in a 24-hour period. So if somebody's not fully vaccinated, they recommend quarantine for 14 days after the last exposure to the infected person. Or if the exposed person had a test that was performed at least 5 days after the exposure, and that was negative in some locations, the duration of quarantine may be shortened. What their guidance is for vaccinated persons is to mask for 14 days after exposure or until a test is negative. And they recommend testing 3 to 5 days after the exposure or when symptomatic. And of course, if they're infected or test positive, then they should be isolated for 10 days after that time period. So I'm going to switch gears now to the vaccines. I'm not going to discuss them as to how they work, but more about efficacy. So this is a summary slide of the COVID-19 vaccine efficacy of selected vaccines based on clinical trials, AstraZeneca, Moderna, Pfizer, Sinopharm, Sinovac, and Johnson & Johnson. And as you probably know, protection against all symptomatic disease varies, and the mRNA vaccines are around 94 to 95% effective. The AstraZeneca vaccine is 67%. Sinovac is at 51%, and Sinopharm is 78%. After one dose of the Johnson & Johnson vaccine, it's 66% protection against symptomatic infection. But they're all quite effective in protecting against severe disease or hospitalization from 21 days after even the first dose of the 2-dose vaccine. So you can see here around 80 to 100% effective against protecting against severe disease or hospitalization. How about in the real world? So this is a summary of different studies that is available on the CDC website. As far as prevention of SARS-CoV-2 infection, 86 to 99% effective for the Moderna and Pfizer vaccines. It's lower for long-term care residents who are usually older and have several comorbidities. The Johnson & Johnson vaccine is at 77%. But again, with prevention of severe disease or hospitalization, they're quite effective, 87 to 98%. And even for asymptomatic infection, 80 to 92% for the AstraZeneca, Moderna, and Pfizer vaccines. And then for household transmission, that is reduced by 40 to 50% in studies of the AstraZeneca and the Pfizer vaccine. And even in older individuals, this is a recent MMWR publication where they looked at the participating hospitals in COVID debt, looking at those that were hospitalized with COVID-19 in persons aged 65 to 74 in the top graph, and then 75 and over in the bottom graph. Pfizer is the vaccine that we've used the most here in the US, followed by Moderna here in the dashed line. And the fully vaccinated in the light blue bars, and the unvaccinated is the dark blue bars. And as you can see, after vaccination started, the proportion of the fully vaccinated patients being hospitalized is quite a bit lower compared to unvaccinated patients, even those who are 65 and over. And the effectiveness is 96% for both Pfizer and Moderna for 65 to 74 years old, and 91 to 96% for those 75 and older. It's a little bit lower for the Johnson & Johnson vaccine at 84 and 85%. In another study looking at almost 4,000 healthcare personnel and other essential and frontline workers. So these participants actually underwent weekly mid-turbinate swabs, even if they were asymptomatic. And of course, if they had symptoms, they underwent swabbing for testing. And about 81% were protected from infection, even with just one dose of vaccination, and 91% protected and fully vaccinated. And they had lower risk of febrile symptoms, 25% versus 63% in the unvaccinated. And only 3 people were hospitalized, and those people were unvaccinated. The vaccinated people had fewer days of symptoms, and they spent 2 fewer days sick in bed compared to the unvaccinated. With regards viral load, there was a lower viral load in partially or fully vaccinated, a shorter duration of viral detection, 2.7 versus 8.9 days in the unvaccinated, and 66% lower risk of viral detection after 1 week. So presumably they are now less infectious if they were vaccinated compared to the unvaccinated individuals. And we can see those results here. This is a graph from CDC as of August 8th with regards healthcare personnel who developed COVID-19 and those who died from COVID-19 and were healthcare workers. And we started vaccination in December. Now this mirrors the outbreak here, or the epidemic curve in the US, but as you can see, there's a lot fewer cases in healthcare personnel after the start of vaccination, and definitely a lot fewer deaths after that. And I think you have the same experience there. How about CoronaVac or Sinovac real world effectiveness? So this was a study out of Chile between February and May. And at that time, they had alpha and gamma variants circulating. So the Coronavac or Sinovac had a 66% effectiveness in preventing COVID-19 infection, but it was actually quite effective, around 85 to 90% effective in reducing severe COVID-19 disease, including hospitalization, ICU admission, and death. How about for variants? So this is data out of the UK, and this is Alpha versus Delta variants with Pfizer and AstraZeneca. And as you can see in this part of the table, the vaccines were less effective after one dose in preventing infection compared to the Alpha variant. They were still quite effective after 2 doses, however. And if you look at hospitalization, they were very effective in preventing hospitalization, comparable and sometimes even higher than for the Alpha variant. So even though they're less effective perhaps in preventing symptomatic disease, they're certainly quite effective in preventing severe disease, even for the Delta variant. I don't have data like that for the Coronavac or Sinovac. There is this preprint study out of Thailand where they looked at serum from people who got 2 doses of Coronavac or people who were hospitalized with COVID-19 in 2020 and 2021 and looked at the neutralizing antibody titer. And this is Coronavac here. This is the wild type virus. This is the Alpha variant. This is the Beta variant, and this is the Delta variant. And as you can see, there were a lot of neutralizing antibodies after Coronavac with the wild type variant. However, with the Delta variant, it was significantly lower. And if you just look at the Delta variant, there's actually fewer neutralizing antibodies with Sinovac compared to people who were infected and hospitalized with COVID-19 in 2020 and in 2021. What that means as far as effectiveness in people is yet to be determined. So as far as rolling out vaccines, of course, considerations include availability. If there is no available vaccine, it's really difficult to roll it out, obviously. And what vaccine is rolled out, again, depends on the availability and accessibility of those vaccines. Infrastructure is important because some of these vaccines require ultra cold temperatures, and some locations may not be amenable for some of these vaccines. Also, how those vaccines will be administered. Will that be in a clinic? Will that be a drive-through? Kind of depends on what available for infrastructure. Here in the US, different states have rolled things out differently. And initially with massive vaccinations, the drive-through locations worked quite well because they could literally vaccinate thousands a day. However, the limiting factor is that some patients do not have vehicles to actually do the drive-throughs, so other vaccine setups need to be made for people like that. And so now they can get vaccines in pharmacies and their physicians. So some clinicians can actually do this in the clinic, which of course is much more accessible for some patients. Now, how do you prioritize who you give to, especially when there is a shortage of vaccine? And I think every country has decided to prioritize healthcare workers because, like I showed earlier, healthcare workers have been affected and have died from COVID-19, and we need healthcare workers to take care of our patients. So they should really be the priority, especially those who have direct patient care. And then next up will be those who are at risk for severe COVID-19. Now, the risk depends on comorbidities, and so the different tiers for vaccination will then depend on their particular risk for severe COVID-19. Communication and education is really important. Unfortunately, I live in a country where there are a lot of people that do not want to have vaccine, even though we have a lot of vaccine. And so there's a big push on trying to get people to change their minds and accept the vaccine. While I'm recording this, there was recent news, at least in the Philippines, of somebody who stated that vaccines cause harm more than benefit. And I would just like to say that the vast majority of evidence is that the vaccine protects thousands of patients from severe disease and death, whereas the side effects are much, much less. They are definitely safe. How about the considerations for loosening IPAC measures and reopening society based on the vaccine? So that depends on a lot of different factors. So the local epidemiology, is this the beginning of the outbreak? Are there a few cases versus thousands of cases? How effective is the vaccine that is being given, and how many patients or how many people in the population have been vaccinated? The presence of variants, are they more contagious? Is the vaccine effective for those variants? And then, of course, the level and the duration of the community closure. Different countries have instituted varying measures of lockdown, if you will. Some are stricter than others. And some that started it early on in the outbreak with very few cases have been very successful. However, the longer the outbreak has been going on and more of the population being infected, it's a little bit harder to do that. And it's hard to do that for a prolonged period of time. It does give a community time to adjust to the outbreak because there are fewer exposures while there is a lockdown. However, when that lockdown opens up or it is not being adhered to, then people will be exposed to each other. And if there are other individuals coming from other locations with variants, for example, then there's going to be another surge, most likely. And this is the epidemic curve of the US. This was our surge in the summer, and this was our big surge in the winter. We started vaccination in December, around mid-December, and that was followed by a nice steep decline in the number of cases. So on May 13th, the CDC said that masks were optional for the vaccinated. Well, that lasted about 2 months. And then we started seeing the surge. And on 7/29 or July 29, the CDC changed their minds and said, now we recommend indoor masking even for the unvaccinated. And that is all because of the Delta variant. At the end of March, there were no Delta variants, at least of the sequence strains in the US. But by July 31st, there were 83% of the isolated strains here, as you can see here in the orange. There was hardly anything here. There was May 8th, and this is July 31st, and it's basically taken over, and it's the majority of the strains here in the US. And data from the UK, when they look at the attack rates among household and non-household contacts of the Alpha and Delta variants here, just looking at the household contacts here in the solid line, this is Delta variant in the purple, and the pink is the Alpha variant. And in a general population, Delta variant infections are about twice as infectious as infections with non-Delta variants. And there was an outbreak here in Massachusetts you might have heard of just last month in July. People were vaccinated and felt safe to be in large public gatherings. They had a big outbreak there around the middle of July. And because a lot of the participants were fully vaccinated, they represented 74% of the 459 cases of COVID-19 in these big public gatherings that were reportedly quite crowded. And of the 133 sequence strains, 89% were due to the Delta variant. On the right side of the graph of the slide, you will see a graph of the viral load in the unvaccinated on the left and the fully vaccinated on the right. And as you can see, the viral load is the same in the unvaccinated and the fully vaccinated, and hence even those who were fully vaccinated could spread the infection. This slide shows data from Singapore on Delta variants. As you know, Singapore has a very highly immunized population. These were from 218 patients who were admitted between April 1 and June 14. The unvaccinated were in the red line, and the vaccine breakthrough for those who were fully vaccinated with mRNA vaccines is in the green line, and viral load, or the CT value, is on the y-axis. And as you know, the lower the CT value, the higher the viral load. Most of the time what we're getting for the other variants are between 20 to 30, but this is around 20, again, higher viral load compared to the previous variants. And as you can see here, the viral load is the same between the unvaccinated and the vaccine breakthrough. There is a difference. So the ones that were vaccinated, their viral loads went down faster than those who were unvaccinated. The concerning thing about this graph is these people here on the right, where 4 weeks into the illness, they still had high viral loads. Now, we don't know if these are live virus or not, because they did not do a test for viable virus. So we don't actually know what this means. But if this is viable virus, then perhaps these patients need to be kept in isolation for a longer period of time. So that remains to be determined. So is it useless to get the vaccine? No, it is not. I showed you that earlier, but here's another graph. This is the US again. There's the 7-day case rate per 100,000 on the y-axis, and the percent of the state population vaccinated on the x-axis. High level of transmission is red, and as you go down to blue is low. And as you can see on this graph, those states that had higher vaccination rates had lower case rates than those states in the US that had lower vaccination rates. But the vaccine works. This is from the Kaiser Family Foundation, where they look at the share of overall COVID-19 hospitalizations by those fully vaccinated versus those not fully vaccinated among those states that reported here. So there are a variety of different states that you can see on the left. And the share of the overall hospitalization among not fully vaccinated is 95% and over in every state that's reporting, whereas the share of overall hospitalization among the fully vaccinated is 5% or less. And if you go to the site and you scroll through, cases or deaths, the percentages are the same, where those who are not fully vaccinated have 95% or higher of the cases or the deaths. So back to the US graph, this is just Florida, which you probably heard has a big surge right now. Looking at the January 2020 surge, or the winter surge, the purple line, which is the top here, is those who are 70 years or older, and this is the admissions or hospitalizations per 100,000 population. And as you can see there, they were the biggest share of patients that were getting hospitalized, whereas the younger people, 18 to 29 in this teal color and 0 to 17 in the yellow or mustard yellow color, were hardly ever hospitalized during that time period. But during this surge in July, there's actually not as much of a difference between the older individuals and the younger individuals here as far as hospitalization rate. And if we just isolate out that 18 to 29 and the 0 to 17 age group, you can see the steep slope of increase in the rate of hospitalizations in those age groups, explained largely by the fact that they were not really vaccinated. So 18 to 29 years old, vaccination rate at this time period is less than 10%. And for 0 to 17 years old, and most of them are not even eligible for vaccination, it is less than 1%. And unfortunately, they are feeling the brunt of this surge and getting to be hospitalized more. So looking at the world in data, as of August 8th. There's certainly some countries like Singapore, Qatar, and Chile that have high vaccination rates. The United States at that time was a little bit over 50%, close to 60%, and it varies by state. The world as a whole, unfortunately, is only at about 30% immunization. And of that date from this source, the Philippines as a part of the population was a little over 10%. And there's a large bit of the world that have vaccination rates below 5%. And how much will be needed for herd immunity? They used to say 70%, but with a more infectious Delta variant, people are saying something about 90%. So maybe we should be looking at something else instead of having herd immunity for infection. Perhaps maybe it's herd immunity for severe disease. And one could argue that maybe we are there even with the Delta variant. Hopefully, we won't have another variant that's even worse and more contagious and more virulent. Well, until we get to the right herd immunity, infection precautions do work. So this was an MMWR last year before we started vaccination. They looked at K-12 schools in Wisconsin that had in-person learning that used masks in those schools. They had smaller groups, 11 to 20 students in a classroom. The staff maintained 6 feet of distance if possible, and they were quarantined after exposures. So teachers reported more than 92% of students used masks. And during those 13 weeks of in-person learning, only 7 of 4,800 students and none of the 654 staff were infected with COVID-19 at school. And this is while there was actually high community spread within the community, which is where presumably those 7 students got it. So using this infection precautions while we're waiting for that herd immunity should work, but we have to adhere to it. One slide on this pre and post exposure prophylaxis. Ivermectin, it does not work, and I'm going to leave it at that. The Regeneron monoclonal antibody, casirivimab imdevimab, was recently published in the New England Journal of Medicine, a subcutaneous injection within 96 hours after diagnosis of household contact, had an 81% reduction of symptomatic infection and 66% reduction of asymptomatic and symptomatic infection. Those who actually got a symptomatic infection and received the monoclonal antibody had a shorter duration of illness and shorter duration of a high viral load compared to placebo. And so at least in the UA, there's an FDA emergency use approval for post-exposure prophylaxis of this Regeneron monoclonal antibody for those who are at high risk for severe COVID disease, who are not fully vaccinated or not expected to mount an adequate response, and for those who are at high risk of exposure to an infected individual because of infection occurring in the same institution or setting, such as being in prison or nursing home. The Mayo Clinic experience is similar to a lot of other institutions worldwide. We did have to deal with supplies, space, staffing issues during that time. We did close the practice, almost shut down the outpatient practice, save for some telemedicine visits. There was an evolution of management, just like everybody did, as we were learning how to better support our patients and how to better treat our patients. We were able to set up infusion areas for monoclonal antibodies as soon as the FDA granted EUA approval, and we have shown that that has decreased our hospitalizations. And vaccine, the experience is different. You may or may not know that Mayo Clinic has different sites in different states of the US. In Arizona, for example, we had a very limited availability of vaccine that we could give here at Mayo Clinic. The state of Arizona decided to centralize vaccine administration. And so basically the state was taking care of that in big vaccination centers up until a few months after starting vaccination. So we actually at Mayo Clinic were going somewhere else to get our vaccine. The nice thing is, because we are a big institution with sites elsewhere, having that team to help figure out how to do things, being able to quote unquote borrow staff from our other sites, say like Rochester, when we were short of ICU nurses or respiratory therapists, was a big help for us. So to sum up, SARS coronavirus 2 is predominantly spread through respiratory aerosols, and prevention of transmission primarily involves control of shared air through engineering and administrative controls and protective equipment. The Delta variant is more contagious and may require change in infection prevention protocol. the vaccines have shown very good real-world effectiveness in prevention of severe COVID-19 infection, including with the Delta variant. And as far as post-exposure prophylaxis, the Regeneron monoclonal antibody, casirivimab, imdevimab, has shown effectiveness in reducing infection. Thank you.
Thank you, Dr. Sibilia. Our third speaker for this session belongs to UPCM Class 1992. After his medical education, he pursued his residency training in internal medicine in UPPGH prior to his fellowship in pulmonary medicine in the same hospital. He later on became an associate professor in UP Philippine General Hospital. He practices as a pulmonary critical care specialist and is currently the chairman of the Critical Care Unit Management Action Team of PGH. Please help me welcome Dr. Jubert P. Benedicto.
Thank you very much for that kind introduction, and I always welcome the invitation from our colleagues. It is indeed my pleasure to be part of this postgraduate course. So in the next few minutes, I would like to highlight certain issues that we do encounter as we go on with our unenviable task of really managing COVID-19 afflicted individuals. We do know that it is programmatic to a certain extent. So that means we follow certain protocols, certain pathway, but definitely we do realize that certain afflicted patients fall in the crevices of the guidelines. That means we have to individualize treatment to a certain extent, tailor fitting our approach to the particular needs of the patient. So I would like to highlight that as well. This is just my disclosure and disclaimer slide. I would like to stress that the perspectives in the next few slides are mine and does not reflect the PGH administration or the societies or our organization I represent. This is the way we now view the COVID-19 natural history. So that means they really start with a stage 1 or early infection or the viremic phase. At this particular juncture, patients will be relatively mildly afflicted or have moderate symptoms. And definitely this is the time where the yield of your RT-PCR is greatest. Subsequently, if the process goes on unabated, they go now into the pulmonary phase. At this particular juncture, the patient now becomes more symptomatic. Dyspnea, shortness of breath are prominent symptoms. And therefore, at this particular juncture, certain imaging studies like your chest X-ray and CT scan have remarkable findings. If they go on unabated, a hyperinflammatory phase sets in. This is the thing that we don't like because hyperinflammatory phase is really associated with dismal outcomes, especially if you fail to intervene. At this particular juncture, organ dysfunction is the more prominent manifestation of the disease. We don't like cytokine storm. Definitely, when we say cytokine storm, we are in that crossroads wherein a lot of inflammation are present already. Inflammatory markers, byproduct of inflammatory processes, overflow from the lungs, and of course, they will now affect other organs. You have some form of hepatitis, renal failure may be a manifestation. Constitutional symptoms becomes more dramatic. Patient is febrile, maybe anorexic, has some fatigue, and definitely at this particular phase, myocarditis may be a manifestation. And so with other gastrointestinal, rheumatologic symptom, even nervous system involvement. So what do we know as of now? Well, from taking off from how the lungs are affected, principally, we do know that there's some form of intrapulmonary shunting because of edema and atelectasis. Intravascular microthrombi may be prominent, and sometimes pulmonary embolism may be a manifestation. There's overall loss of lung perfusion regulation. Definitely, that would result in reduced lung compliance and increased dead space. The patient at this particular juncture has some CO2 retention and is really anxious, and in terms of work of breathing, it is tremendous in terms of his ability. So dyspnea is a prominent symptom. As you can see from the lower diagram, our antivirals with the main dictum of reducing immunosuppression has some role in the early phase. Subsequently, we do embark on certain anti-inflammatory strategy. Patient may be now subjected to prone ventilation, some form of anticoagulation, especially at this particular juncture of the disease process. If, unfortunately, the patient may need mechanical ventilation, protective lung ventilation strategy, prone ventilation, or even ECMO will be the main treatment modalities. So as you can see, depending on the severity of manifestation, we do have interventions to possibly counteract their effect, standing or being founded on the pathophysiology of the disease. I would like now to highlight what we have in terms of the living recommendation from the Philippine COVID-19, which I accessed last May 28, 2021. So in terms of an antiviral agent like remdesivir, the guidelines is against the use in patients with good O2 saturation and who do not require oxygen supplementation. Inconsistently with other international or global guidelines, remdesivir, in addition to dexamethasone, are more beneficial among those who may require oxygen supplementation, especially if they have oxygen saturation of less than 94 at room air. Of course, because of equity access issue, it is against the use of remdesivir among patients who are already on invasive mechanical ventilation. The last bullet may be contentious, but remember, we are looking at a resource which is quite limited and may not be readily available, especially during the early parts of the pandemic. And therefore, the main justification behind this particular statement. How about tocilizumab? Tocilizumab, which is an anti-IL-6 agent, principally acts at the early phase of the inflammatory cascade. And therefore, they have seen the role of tocilizumab to evolve. As of now, it is being recommended in addition to systemic steroids among individuals with rapid respiratory deterioration, especially those who may require high oxygen support and manifest as elevated biomarkers. The recommendation there is quite strong. Tocilizumab should not be used among patients who do not require oxygen supplementation. So as you can see, the role of tocilizumab is being niche. It's quite focused as far as the local guidelines is concerned. How about systemic steroids like your dexamethasone? Well, considering the gamut of studies behind it, right now it is recommended among those who require oxygen supplementation. High quality level of evidence associated with strong recommendation. So that means severe to critically ill patients will require dexamethasone. You do not use it among patients who will not need any oxygen supplementation. How about anticoagulation? So I'm talking about low molecular weight heparin, like your enoxaparin. So the guidelines is for the use of prophylactic anticoagulation among hospitalized patients unless with contraindication. When we say prophylactic, for enoxaparin, it is 40 milligrams sub-Q once a day, as opposed to its intermediate use, which is usually pegged at 40 milligrams sub-Q every 12 hours, versus, let's say, the therapeutic use, which is 1 milligram per kilo per dose every 12 hours. So the guidelines is just pushing for prophylaxis rather than therapeutic anticoagulation among critically ill COVID patients, unless, of course, you have demonstrated your pulmonary embolism manifestation. So this is from the Society of Critical Care Medicine. So as you can see, quite consistently, if we're going to concentrate severe to critical COVID-19, Foundation treatment should be systemic steroids as well as pharmacologic VTE prophylaxis. They do prefer dexamethasone over other corticosteroids, but I would say at this juncture that there are some studies to tell us that maybe some other steroids like your methylprednisone may have a role depending on the severity and the manifestation of the COVID-19 patients. Do you consider using remdesivir among those who are severely ill? Among critical ill patients, you avoid remdesivir, especially if the patient is already intubated. Convalescent plasma is out, as well as hydroxychloroquine. In terms of respiratory support, addressing the oxygen supplementation issue, it is preferred that you start with low flow oxygen, that means by nasal cannula, and subsequently graduating depending on the patient's needs and manifestation. If the patient may need face mask or even non-invasive ventilation like your BiPAP or CPAP, as well as high flow nasal cannula. As you can see, as you go on and progress with the oxygen supplementation, you should always keep at the back of your mind that you should be monitoring these patients closely and that the need for intubation should always be there. And that means you should be able to anticipate once you monitor these patients, ideally in an intensive care unit setting. So this is just a good diagram summarizing everything in terms of ventilatory support. So the green bars, as you can see at the left side of the screen, will just highlight the initial approach. I would like to stress that, of course, we don't like over-oxygenation. So as you can see, it's just a sweet spot. We maintain an O2 saturation of between 92 to 96. In fact, for other COVID-19 patients, especially those who are critically ill in terms of affectation, you may just aim for sometimes 87 to 88 O2 saturation. You can see the right side of the screen for additional care. Of course, we are highlighting that the patient should have cardiac monitor, pulse oximetry, the need for analgesia and sedation, as well as possible access to renal supportive therapy. In the blue bar, principally, it was thought of initially that there's a type L and type H, the extremes of the spectrum of COVID-19. Certainly, because of the Gattinoni model, there may be type L, that means low elastance, increased compliance, and low responses to PEEP. At this particular juncture, such patients may need a tidal volume of around 6 to 8 ml per kilo. Prone position may work in terms of strategy, as opposed to your type H, which is associated with high elastance, low compliance, and good responses to PEEP. So this is your typical ARDS patient. I do know that a lot of patients are in the middle between type L and type H, which, as I've mentioned, are the extremes of affectation. And therefore, it is very advisable to individualize our approach with due consideration with the pathophysiology of the disease, and of course, in terms of how COVID-19 has affected your particular patient's respiratory system. This is just from the Philippine College of Chest Physicians, putting together everything in terms of concept. So it's basically the same, monitoring your patients in terms of severity of affectation. And then subsequently, there's that escalating oxygen support, highlighting the need for safety for healthcare workers. And these are just your protective lung ventilation strategy, looking at optimal PEEP, and then subsequently possibly invoking low tidal volumes. As you can see, all throughout, you are being asked to monitor your patients, and it is indeed advisable to possibly have advanced directive by discussing with the family members end-of-life issues, which is, of course, uncomfortable in a lot of instances. This is from the Philippine General Hospital guidelines. As you can see, we just put everything because not all patients who are being seen in our hospital are, of course, pulmonary specialists. And we would like to have a standardized approach. So that means basing it, anchoring your intervention on the severity of COVID-19. You can see as well the main interventions highlighted in bold letters, as well as the possibility of enrolling our patients to clinical trials. So you can see here, tocilizumab is here, quite similar to what the Living COVID-19 guidelines is telling us. Of course, because of its shortage, we may go on and resort, let's say, to baricitinib or to possibly increasing dose of your steroids. We are indeed at the threshold of a lot of things. No? We are facing rapidly evolving knowledge on a disease that we have really not, put our hands down to it. We do not completely know COVID-19. Yet we are being asked to act promptly and decisively at the front lines. So we frequently have to tell ourselves to just keep calm and to let science speak. However, in a lot of instances, we need to keep an open mind in order to adapt to the changes. Did your initial action now being questioned because the concepts are not working in terms of real life issues? So you should be amenable to change your ways as well, to accept what is working and to possibly change or alter those which are not. With that, I would like to thank you again for your attention and thank you once more for the kind invitation.
Thank you, Dr. Benedicto. Now we proceed to the open forum. The question and answer portion will be moderated by Dr. Regina P. Burba, an internal medicine infectious disease specialist. She is currently the head of the Hospital Infection Control Unit in PGH. She will be accompanied by Dr. Jillian Francis Lee, a provincial health officer of the province of Dinagat Island.
Hello, good afternoon, everybody. Congratulations to all our speakers. I'm sure everybody will agree that we really have a very powerful panel today who gave us wonderful and informative talks on COVID-19. So just as an introduction kaagad, no, Dr. Sevilla couldn't be with us live tonight. So but she already sent a video of frequently asked questions. So maybe we could run that right now.
The first one is, how is COVID vaccination for pregnant women in the US going? Is it widely accepted or not? Unfortunately, COVID vaccination among pregnant women is not widely accepted. The CDC recommended it for pregnant women about a month ago, and the vaccination rate hasn't really changed much since that recommendation. It stands now at about 25% overall as of September 11th, from a low of 13.5% in Black non-Hispanic pregnant women to the highest in the Asian pregnant women who have a 35% vaccination rate. It certainly has a lot more room to improve. The next question, is there a standard COVID home care program in the US for pedia and adult asymptomatic and mild cases? The CDC has the same recommendations for isolation precautions and the duration of isolation precautions for adult and pediatric patients, so that is the same. The treatment at home is basically symptomatic treatment, so the use of acetaminophen, for example, for fever. There is the monoclonal antibodies, and those have US FDA emergency use approval for adults and children at least 12 years of age and at least 40 kilograms of weight if they have risk factors for progression to severe disease. Otherwise, treatment is basically for symptom relief. In the Mayo Clinic, clinicians do have the option to refer patients for the remote monitoring program. And in that program, patients are provided by Mayo Clinic a tablet, a Bluetooth enabled blood pressure monitor, a thermometer, and pulse oximeter. And they report their symptoms and vital signs 2 to 4 times a day. It is clinically supported from 7 o'clock in the morning to 11 o'clock at night, 7 days a week. It is staffed by nurses, and they have physicians on call if they have questions or concerns about particular patients. Next question. As a standard protocol, do you repeat the RT-PCR on Delta patients prior to discharge? The answer to that is no. As you all know, the RT-PCR could detect SARS-CoV-2 in clinical samples for a prolonged period of time in some patients, which may extend weeks for some patients, even though they are no longer infectious. And so it is not clinically relevant to do RT-PCR testing for patients. So the isolation duration would be the same. It would be 10 days after symptom onset for most patients. We extend that to 20 days for people who are immunocompromised because they tend to shed viruses longer, or those with severe disease as recommended by the CDC. The PCR testing for patients being discharged really does not play a role in determining if patients need to remain in isolation when they're discharged from home or not.
So Jillian will ask the next question. Jillian, I think you're muted.
All right, good evening. While we regret that Dr. Sevilla was not able to be present for this session due to the time differences, we are grateful for the presence of our other two speakers, Dr. Felizarta and Dr. Benedicto. So, questions from the audience. We all know that the RT-PCR is our gold standard for diagnosing COVID-19. However, due to constraints in the availability of reagents and the availability of molecular testing labs, many primary care facilities and many patients rely on the rapid antigen test. Could you elaborate a bit more on the use of the rapid antigen test as a screening tool and what this means for patients and other primary care providers and other physicians?
Yeah, I can answer that. Can you hear me?
Yes, we can hear you.
Of course, in hospitalized patients, we don't use antigen testing, but in the community settings, you can use an antigen test just because it's more attractive, it's cheaper, it's faster. The problem is it has a lower sensitivity compared to the RT-PCR. So if you have a patient who's symptomatic and you have a high clinical suspicion for COVID and the test is negative, then you have to confirm it with an RT-PCR. If it's positive, then you believe it. Now, in non-surge conditions, let's say there's no surge anymore, and you're testing an asymptomatic patient, and the clinical suspicion is low, then you probably, and if it's negative, you probably have to confirm it with an RT-PCR. So it's the opposite.
Okay. I'd like to ask the next question to Dr. Joubert and maybe also to Dr. Felizardo. How do you think the pandemic will end? Can you give us your fearless forecasts?
That's a difficult question. So how do you think the pandemic will end? I don't think we'll have a good grasp at the situation. That's coming from me as a pulmonary critical care specialist. I feel that the story of COVID is still not yet unfolded. We still last year, early this year, we had some grasp on it, and then subsequently with all the variants, some computations went awry as well. So to be honest, I don't know how will it end. I just feel that, in the new normal, we still have to wear our mask and probably practice social distancing. And I feel that the vaccination will be a regular thing as well.
Thank you, Dr. Benedicto. Any thoughts, Dr. Felizarta?
Well, first of all, the COVID mutation rate is still slower than influenza mutation rate. So it's at least 2 times slower. By this time, if this was influenza, our vaccines will be useless, right? They will be useless by now. So so influenza has a faster mutation rate. Second is we have more data that if you get a natural infection or vaccination, that it could last for a long time, unless you have a very resistant variant. So I think it will, after a few years, it will be more of like a influenza. We probably will need. It depends on the variants. We probably need regular boosting, but I don't think it will be yearly. I don't think it will be like influenza, just because the mutation rate is slower.
Thank you for your answers. Okay.
Right. Thank you. Speaking of vaccination, there are a lot of questions in our Q&A box regarding vaccination, the effectiveness of various vaccines. We just like to ask, in your experience and based on the studies you know of the comparative effectiveness of various vaccines, and about the approval for the Pfizer COVID vaccine in children, seeing as this recent surge of Delta variant cases have resulted in increased incidence of infections among children.
Well, I could probably answer that. Well, in terms of vaccine efficacy versus infection, most likely, most of the Sinovac will probably be less than 50%. We already knew from the phase 3 clinical trial that the protection rate is 50%. So with the Delta variant, it will be lower. We also have some data, even with Pfizer, it's less than 80%. The most important thing is the efficacy versus hospitalization and death. So with Pfizer and especially Moderna, it's more than 90%. Although we have now data for 65 and above, that there's some waning in the protection. So for example, Pfizer, it's going down between 80 to 90%. Now for Sinovac though, in terms of protection against hospitalization, we have data, for example, from Chile. Dr. Civil mentioned that it's about 85% effective versus hospitalization in Chile. Now remember, at the time in Chile, only 30% have gamma variants. In Brazil, they did another study, and at the time, the gamma variants was 70%. The effectiveness of Sinovac versus hospitalization was 75%. So it was lower when you have more gamma variants. Now we know from neutralizing studies though that gamma variants is almost equivalent to Delta. The worst is Beta. Beta is the worst. So I think for Delta we don't have any data yet, but it's probably going to be the same thing, 75 to 85% versus hospitalization against Delta for Sinovac.
Okay, thank you, Dr. Felizarta. The next question is for Dr. Benedicto. I'm reading from the Q&A box. PhilHealth relies heavily on RT-PCR positive tests to justify case inclusion for the Z packages. But when the PCR test is negative, they will flag the case as not COVID despite the symptoms. What can you recommend to PhilHealth to remedy this situation?
Definitely, the professional groups are into dialogues with PhilHealth because what's happening on the ground is quite different as what can be captured by any policy. So that's our take on it. So I think the professional groups are into communications with them, and they are opening their at least lines in terms of dialogue that, let's say, for example, if you have a compatible presentation, even if you have an RT-PCR which is negative, if the clinician is committing that it is COVID, then that the possibility is there. They're open to conversation that it can be labeled as COVID. For the Philippine College of Chest Physicians, for example, before, PhilHealth was quite close-minded in saying that it's only critical if the patient will need ECMO or is intubated. So we propose that what if the patient, let's say, has indication for being intubated, and because we ran out of ventilators, we could not intubate the patient, or the patient has advanced directive. So they are opening up their minds slowly, and we are in the process of drafting circulars with them to be more attuned to what's happening at the front line.
Okay.
Thank you for the answer. Another question from our chat box. Does COVID have a developmental or physiological effect to newborns who have been born of mothers who tested positive for COVID during their pregnancy?
Yes, we don't have good studies yet as far as looking at the developmentals, looking specifically at the babies born from COVID positive patients. No? But I do know from at least our OB colleagues that, let's say, in the next few months that they're monitoring the kids, there seems to be no developmental delay. No? It seems like they are still normal, but of course, we would wish for more long-term studies looking at this possible aspect.
Okay, the next question, I'd like to get the opinion of Dr. Felizarta. If you were the DepEd chairman, so that's the Department of Education here in the Philippines, will you allow resumption of face-to-face classes for elementary and high school and college students? And maybe you'll tell us how it has been in the United States, where you've been able to open up the schools and universities with face-to-face classes.
Well, yes. The difference is we have a very high vaccination rate. Although if the problem is that we know that, at least for 12 years and below, it's still not approved yet. So most of these children are unvaccinated. But the problem is the transmission to the parents or patients who might be immunocompromised or the elderly. So you need a very high vaccination rate. Second is you can do probably we have some studies, for example, in North Carolina, that it even at the time with low vaccination rate, the secondary attack rate was quite low when you have universal masking. So if there's universal masking in the what you call this educational institutions. The other one is testing. You can test them like if you do RT-PCR saliva, for example, they've been using it in colleges here in the United States. It's once a week. They test them once a week using RT-PCR with saliva. Or you can do antigen testing, but antigen testing, you probably have to do it 2 to 3 times a week. The problem is the Delta variant. The Delta variant is much more transmissible. So you probably have to, test even more frequently. So I think that the solution will be if there's a high vaccination rate, universal masking plus testing. If you can test the children, then you can open up. You can open up the face-to-face because there's a.
Thank you for that response, considering Okay, thank you for that answer. Since our government is considering the resumption of face-to-face classes, if the previous question made you the chairman of DepEd, the next question is asking, considering our present health protocols, what additional actions would you recommend to our government to contain or to lower the spread of COVID-19?
Kaninong question yon? Para kanino?
For either of you po. For either of our speakers.
For me kasi I think what's lacking right now from the government side is really strengthening the community response. So yung community pa lang, for me, the whole thread So it's the community response that we really need to invigorate and really, put some effort into it. Sa community, we do know yung hindi lang yung isolation, kundi pati yung let's say contact tracing and everything. Then the proper compensation should be poured in as well dito sa community. And then subsequently, as a frontliner, ang main main take ko is that for the information being given by DOH, I feel that ER beds is lost in the equation. We do know that our ER is the main gateway in terms of the hospital kasi we are concentrating already in the ICU bed utilization. Yet, of course, if our ER beds are really quite full, then we could not, shepherd the patients inside the ICU. So it's really quite more reflective of what's happening on the ground. If we do have a good take as far as the community status is concerned and then the ER status, I think that's what's not being captured in the current equation.
Okay, thank you, Dr. Benedicto. Actually, we've run out of time, so we will be answering most of the other questions in the Q&A box along the way. No? So can we just hear the last parting messages from our two speakers, Dr. Felizardo first and then Dr. Benedicto?
Well, remember, the vaccination is very important. That's our main goal. But even with vaccination, there's always a chance of getting a breakthrough infection, although it will be milder. So in order to decrease the breakthrough infection, remember, you still have to do you have to still wear your mask and maintain social distancing.
Okay, thank you.
Yes, so on top of what Dr. Felizardo mentioned, we could not overemphasize the importance of vaccination. And I think at this point in time in our pandemic response, it should really be mobilization. Ang pet peeve ko talaga community. My pet peeve is to really mobilize the community effectively and then possibly, churn out the right data for us to really be more responsive in the current pandemic. That's all. Thank you.
Okay. Thank you, dear speakers and moderators, for that very riveting discussion. We would like to award the Certificate of Appreciation to Dr. Franco Felizardo for his invaluable contribution as a resource speaker on COVID-101 microbiology and immunology and COVID-19 molecular and cellular response during the UPCM Grand Scientific Symposium. This Certificate of Appreciation is given to Dr. Maria Teresa Sevilla for her invaluable contribution as resource speaker on COVID-19 infection control, prevention, and vaccines. This Certificate of Appreciation is given to Dr. Jubert Benedicto for his invaluable contribution as a resource speaker on COVID-19 treatment, antiviral, and ancillary. We would also like to award the Certificate of Recognition to Dr. Regina Burba and Dr. Jillian Francis Lee for their contribution as moderators for the focus session on COVID updates and forecast, given this 21st day of September 2021. Signed by Dr. Maria Assumpta Cecilia Serrano, President, UPMAS Davao, Dr. Teresa Luisa Cruz, Director, Postgraduate Institute of Medicine, Dr. Charlotte Chong, Professor and Dean of UP College of Medicine, and Dr. Lara Teresa Aleta, President, UP Medical Alumni Society. Thank you, doctors.
Good evening, everyone. For tonight's Twilight Symposium, it is my privilege to present our distinguished speaker, She graduated summa cum laude of Bachelor of Science in Zoology in UP Diliman, and from then on continued her excellence by being Doctor of Medicine from the UP College of Medicine, otorhinolaryngologist head and neck surgeon par excellence from the UP Philippine General Hospital residency training, and subspecialist as otologist, neurotologist, skull-based surgeon from her fellowship education and training from the Harvard Medical School and from the University of Toronto. She also has a PhD in medical sciences from the Radboud University. Presenting to you, Research Professor 12, National Institutes of Health, University of the Philippines, Manila, Clinical Professor, UP College of Medicine, Department of Otolaryngology, Head and Neck Surgery, and our beloved Dean, the Dean of the University of the Philippines, Manila College of Medicine, Dr. Charlotte Martinez Chong.
Thank you, Tej. May I share screen? Di pa yata maano. Can you please let me share my screen, please?
Yes.
Dan and Pao, please share the screen to the Dean or you will not get paid.
While waiting,
Let
me thank all our previous speakers. It's really been a very an amazing conference so far, and I'd like to again thank the organizers and Tej here, the director of PGIM, for mounting this really very amazing Grand Scientific Symposium. So if I'm able to share screen, I would be able to start my talk already.
You can share screen na pa, Dean.
Yeah, pa, you cannot start screen daw while the other participant is sharing.
Oops, akin na pa, Dean. Thank you.
Okay, so let me, thank you. Can you see my screen?
Yes, Dean.
Okay, so I'll go to presenter's view.
Yes, Dean, correct.
Can you see my first slide?
Yes, we can see it.
Thank
yes,
you.
ma'am.
So I'd like to thank you for the opportunity to be the first speaker for the Twilight Symposium. And I'd like to thank our sponsor, Abbott, for allowing me to choose my topic. And the topic that I chose is updates in management of vertigo. You know, there's a reason why I became a neurotologist. The reason is when I was a clinical clerk, I fell down the stairs and I lost my whole surgical rotation because from the concussion. I was vertiginous for 1 whole month, and I thought that I will never finish medicine. And that has made a great impact on me, how vertigo can really make one suffer. And I basically was piqued by the fact that maybe I should learn more about vertigo as a disease condition. And then the other story is, of course, how I wanted to be a cochlear implant surgeon. So this evening, I'd like to first emphasize that vertigo is not really the same as dizziness. When you talk about dizziness, you might be talking about presyncope, disequilibrium, other subtypes, and not necessarily vertigo, which is really the illusion of motion of the self or of the environment. So there's actually a sensation of motion. And that prevalence of dizziness is actually very high, with about 35% of adults have vestibular dysfunction, and increasing frequency among women or also in the elderly, with about 10% increase every 5 years. So the data is staggering, and it's really very important for general practitioners and specialists as well to be able to manage patients with vertigo. And the approach that I'd like to propose to you this evening is that the fact that it need not be a daunting experience if you just become very systematic in the way you approach patients with vertigo. I'd like to be able to first outline the discussion, which will actually focus on history taking, examination, and some new classification of conditions, and then move on to diagnosis and treatment of peripheral vertigo. And I will probably just focus on the 5 more important pathologies: the acute unilateral vestibulopathy or vestibular neuritis, BPPV or benign paroxysmal positional vertigo, Meniere's disease, vestibular paroxysmia, and superior canal dehiscence syndrome. And last, I will probably just mention a few things about diagnosis of vertigo during this COVID-19 pandemic. So history is really the most important part of our evaluation. Clinical history should be carefully obtained, and there's a tip here, and that's probably how you might be able to organize it in your mind, and that's 3Ts and an A. You want to be able to know the type of vertigo, whether it's episodic or persistent, or you want to know the time course and frequency of the attacks. You want to be able to know the duration, basically, whether it's minutes, hours, or days. You want to know the triggering or alleviating factors. Let's say, is it provoked by a certain head position change, or is it provoked by certain sound or loud sounds, or is it provoked by some form of pressure, for example, or what you call the Chinese restaurant syndrome after eating a lot of salt, maybe. You want to know what alleviates the attacks, whether it's just basically making the head still, for example, and not doing anything, or focusing on one target. And you want to know the accompanying or the auditory or other neurological symptoms so that you'll be able to basically localize where the disease is. For example, if you're talking about oral fullness, tinnitus, and hearing loss, then more or less that's localizing. You'd know that probably it's in the ear or the inner ear, whereas some sequelae like loss of memory, motor, or sensory weakness would probably point to a neurological problem. So here's another slide that emphasizes the time course, the type, the triggers, as well as the accompanying symptoms. So if you have a patient, for example, with headaches, hypersensitivity to light sound, that's probably migraine. But if you have a patient with a blurring of vision or double vision and paresis and ataxia, then probably you're looking at a possible central nervous system pathology. Now, of course, you have to be able in your history to ask about the possibility of intake of phototoxic drugs. We know that aminoglycosides can cause vestibular hair cell damage, anti-epileptics can cause cerebellar toxicity, tranquilizers can, of course, depress the central nervous system, antihypertensives can actually cause postural or orthostatic hypotension, alcohol can actually change the gravity of the cupula, and anti-cancer medications or anti-neoplastics or chemotherapeutic drugs can sometimes cause cerebellar toxicity. And anticoagulants can sometimes predispose you to having hemorrhages, not only in the brain, but also in the inner ear. So with that said, it's very important that basically one should be able to differentiate between peripheral and central vertigo. I think what makes this a daunting experience for some of the physicians that natatakot tayo if whether one might be dealing with a central vertigo or a stroke, and one might miss out on that. So that if the patient comes to you in the emergency room, the first thing that you'd like to do is to be able to differentiate between peripheral and central vertigo. And I'd like to be able to propose to you that it's highly possible for you to be able to differentiate between the two. One is looking at episodes of vertigo, and usually if it's central, it's usually chronic and unremitting. If it's a sudden onset with nausea and vomiting and some auditory symptoms, then probably that's peripheral. But if it's there's no auditory symptom but rather neurological symptoms, then that's a giveaway. Then probably you're dealing with central nervous system pathology. If there's nystagmus, maswerte ka, because if there's nystagmus, you'd be able to differentiate between central and peripheral just by asking the patient to fix on a target. Ilagay mo yung finger mo and ask the patient to look at your finger. If the nystagmus is suppressed by fixation on the finger, then that's probably peripheral. Whereas if it's not suppressed by visual fixation, then that's more likely central. Or maybe the direction of nystagmus. Usually it's direction fixed and horizontal in peripheral, but it may be vertical, oblique, or disconjugate in central, or you can have bilateral gaze nystagmus in central. And again, as I told you, the accompanying symptoms of whether there's auditory or neurologic symptoms can be a giveaway as well. The effect of fixation, I already told you about that, and the direction of nystagmus is very important, and also the effect of gaze. If you have a patient whose gaze nystagmus changes in direction when looking at the right and the left, then that's probably a central nervous system pathology. Now, in some cases, it might be difficult for the patient to describe the symptoms. They wouldn't remember the first attack of vertigo. They wouldn't remember the last attack of vertigo. And if you ask them about duration of vertigo, they will say, lagi po akong hilo eh. So if that's the case, then you might be not dealing with an organic cause or vestibular cause. And that's the time that you have to rule out psychogenic vertigo because the duration is like a flash. It's the frequency is not very clear. It's not worsened by head movement. There's no ataxia. And what you can do is what you call the hyperventilation test. You just ask the patient to breathe in very deeply for about 1 minute and ask the patient, is this something that will mimic your spell? And if they say yes, then that's probably psychogenic vertigo. And if you ask about phobias, they don't like lining up in grocery stores or being in an elevator that's crowded because it seems that they are going to pass out, and that's a psychogenic vertigo. Whereas a vestibular cause of vertigo is very, very clear-cut in terms of the first or last attack of vertigo, because the patient will always remember that. Because they thought that they were going to have a stroke, they will always remember the first or last attack of vertigo. And usually there's nausea and vomiting, especially when you're talking about an acute vertigo episode from an acute unilateral vestibulopathy, as you see here in your screen. Of course, if the patient has a vertigo that's provoked by a certain head position that's lasting only less than a minute, that's probably BPPV. If the patient has vertigo that's lasting several minutes to hours, but not more than 24 hours, and associated with oral pressure, tinnitus, or some fluctuating hearing loss, then it's probably Meniere's disease. But if you have a patient who has more than 10 attacks of vertigo in a day, lasting a minute or so, and there are no other auditory symptoms, then you might want to rule out vestibular paroxysmia. And there have been cases that I've encountered who will not be categorized in any of these pathologies, but they have this brain fog. They cannot concentrate, and when they're in a mall, they're very irritated. They don't like hearing loud sounds. Sometimes even a cell phone ring is very irritating to them. Then you have to rule out a superior canal dehiscence syndrome. So this is a very busy slide, but just to mention that, again, you have to look at whether it's positional vertigo, and if it's more than 1 minute, of course, scupulolithiasis. If that's less than 1 minute, then it's canalithiasis of BPPV. But there are other syndromes that you have to consider, especially if it's unremitting, even with treatment like particle repositioning maneuvers. And again, the presence of other neurologic symptoms might point you to either a TIA or a stroke. But the most important thing is that, again, if it's provoked by certain sound, for example, or pressure, then that's probably superior canal dehiscence syndrome. Now, this is a diagnostic matrix that's basically looking at the presence of or absence of oral pathology. For example, if the patient has episodic vertigo lasting minutes to hours, and the patient has frequent fluctuating hearing loss, then you have to rule out Meniere's disease. However, if it's persistent dizziness or disequilibrium with auditory symptoms that's progressive hearing loss or unremitting tinnitus, then you have to rule out acoustic neuroma. If it's a patient who has vertigo lasting less than a minute with no auditory symptoms, the most common is benign paroxysmal positional vertigo. And if the patient has a vertigo lasting more than 24 hours with no hearing loss, with nausea and vomiting, then you might have to rule out acute unilateral vestibulopathy, or what you termed before as vestibular neuronitis. So just to differentiate between Meniere's disease and acoustic neuroma, because they're very similar to each other, I think the most important thing is that in Meniere's disease, if you do the hearing test, you'll see probably a low frequency sensory neural hearing loss. Whereas if you do a hearing test for acoustic neuroma, you'll be able to see a high frequency sensory neural hearing loss. In both cases, there could be tinnitus. In both cases, there can be vertigo or imbalance. And in both cases, there can be oral fullness sometimes. And therefore, it's important to do, aside from your history taking, some form of neurologic examination, because if the patient has cranial nerve neuropathy, if the patient will fall to one side consistently, then you might be dealing with an acoustic neuroma, especially in the face of a patient with facial paralysis, for example. Or, of course, we look for other signs like Hitzelberger sign. And the treatment is, of course, when you're dealing with acoustic neuroma, it's usually microsurgical resection or stereotactic radiation, whereas in Meniere's disease, it's usually just medical treatment, beta-histine, diuretics, and, of course, avoiding caffeine, alcohol, tobacco, salt, and stress. Now, the bedside examination of vestibular system that we go back to, again, you'll have very important 4 aspects of that examination. One is the nystagmus, as I told you already. And I would like to introduce to you the fact that you might be able to do what you call head impulse test. And the head impulse test is something where you basically move the patient's head briefly to one side and look for a corrective saccade in the eyes. That's really a test for vestibulo-ocular reflex function. You can also do what you call the positioning maneuvers, like the Dix-Hall-Pike test, as you can see in the picture below, where you put the patient's head hanging about 30 degrees over the edge of the bed. And that's looking for what you call geotropic nystagmus, or nystagmus that is actually beating towards the floor. But if you see that the patient's nystagmus is actually beating towards the ceiling, and there's no latency, there's no fatigability, and the patient doesn't seem to be complaining of vertigo, even though you're seeing nystagmus, then that's probably pointing to a central pathology. So in cases of BPPV, it's very classic. There's a geotropic nystagmus that's beating towards the floor. There's a latency of about 5 seconds. The duration of vertigo or nystagmus that you will see, torsional, horizontal, beating towards the floor is around in the realm of around 10 to 15 to at most 30 seconds. When you repeat the maneuver, it will usually go away. The last test is doing a Romberg test, and as you can see in the picture here, you can actually make it more difficult for the patient by asking the patient to put one foot in front of the other and do what we call a Gendrasic's maneuver, and then the patient has to close the eyes, and you can see whether there's a tendency to fall to one side. Now, in the ER, if you're going to rule out acute unilateral vestibulopathy and be able to differentiate it, for example, from a stroke, because the history can be very similar, you can do the head impulse test. Because in the head impulse test, you expect it to be positive if it's an acute unilateral vestibulopathy. But if you see that the head impulse test is negative, then that's a hint that that patient might be suffering from a stroke. And it's even more sensitive than a CT scan. You can also do tests for nystagmus, and you can also test for what you call skew deviation by putting your eye over one eye and then putting it on the other side and looking for a corrective vertical movement, or what you call a skew deviation. I don't know whether this will work, but this is I got from the YouTube.
That the eye is skewed and moves medially and diagonally upward to look at your nose.
So that's how you are able to see a skew deviation. So if you're ruling out a possibility of the stroke, the best study is actually what you call a DWI, or diffusion weighted imaging MRI, to rule out a stroke. And here you can see a lateral medullary infarct in a patient with acute onset of vertigo. On the other hand, a patient who will have several episodes of vertigo during the day, which is not likely, for example, in Meniere's disease, and it's usually the duration less than 1 minute, then you might be able to do an MRI that shows a vascular loop, or a loop of ICA that can go inside the internal auditory canal. On the other hand, those patients with progressive hearing loss, unilateral hearing loss, unilateral tinnitus with disequilibrium that doesn't want to go away, you'll have to rule out an acoustic neuroma. And you can see here at the bottom right side of the screen of a contrast-enhanced CP angle tumor in a patient with chronic disequilibrium. So once you've made a diagnosis of acute unilateral vestibulopathy, then you go for treatment. And the treatment of choice is really giving steroids like methylprednisolone at about 100 milligrams per day for 3 days, and tapering every third day by 20 milligrams until it's done. So in a matter of around 2 weeks, you should be finished with your steroid treatment. You may also want to give beta-histine at 48 milligrams per day, because there's really evidence that beta-histine, among all other drugs, will be able to facilitate central compensation or adaptation. And that's because of the fact that it may promote neuroplasticity. There's also, of course, the need for doing the vestibular exercises. And this is something that can be done even at bedside. You ask the patient to look up, down 20 times, look to the right, left 20 times. Even if they cannot stand yet, they can already do the vestibular exercises as early as day 3. And you need to be able to encourage them to do the vestibular exercises, again, to enhance vestibular or central adaptation. Now, this is just the New England Journal of Medicine article of Stroop that showed that methylprednisolone as a lone treatment is actually a very good treatment. But there's a more recent study that from Sjogren et al. In otology and neurology that shows that early treatment is very important. If you just get delayed by 1 day or up to 3 days, that's already a significant change in the percentage of patients who will be able to recover fully based on normal caloric test results. So those patients who have been treated within 24 hours, 100% of them actually had normal caloric tests at follow-up after 3 months. Symptomatic treatment of acute vertigo, of course, will still also include vestibular suppressants in the in the initial stage where you might want to sedate the patient. For example, you can give ondansetron to as an antiemetic. You might want to give diazepam in order to dampen the difference between the firing of the right and left vestibular neurons. But you can only do that for a few days. And you need to be able to give beta-histine because, again, as I told you, you need to be able to activate the vestibular system. There's also evidence that beta-histine can also improve the blood supply and therefore also control nausea, vomiting, and vertigo. The beta-histine actually as a drug in the REVERT study has been shown to be the most preferred drug or globally compared to other drugs like piracetam, ginkgo biloba, benzodiazepines, and antihistamines. And we can see here that it's the drug of choice in most cases of peripheral causes of vertigo. Vestibular exercises can be done at bedside, or you can see here that you might want to just improve the vestibulo-ocular reflex function of the patient, and both the static, like standing on a foam or walking, are all exercises can be done. And there's really class 1 evidence that vestibular exercises can actually improve the central compensation because of somatosensory substitution. So we now move on to Meniere's disease. There's now a new diagnostic criteria for Meniere's, and that means we may have to consider that there has to be a duration of vertigo lasting 20 minutes to 12 hours if you want to make a definite diagnosis of Meniere's disease. You need to be able to do an audiometric exam or pure tone audiometry to show the low frequency hearing loss, that is a more than 30 decibel loss at frequencies lower than 2000 hertz. There's fluctuating tinnitus or oral fullness in the affected ear. That's not accounted for by any other vestibular diagnosis like superior canal dehiscence. The treatment of choice for Meniere's disease as well as for paroxysmal vertigo is really beta-histine, but you need to be able to give 48 milligrams per day for at least 3 months. Again, beta-histine's efficacy is based on facilitating compensation after vestibular deafferentation, which may happen in a subset of patients with Meniere's disease, especially those who are already burning out in terms of their Meniere's disease condition. Beta-histine dihydrochloride also showed significant reduction in the number of attacks as well as the intensity score and duration in Meniere's disease. And the preferred dosage is around 16 milligrams 3 times a day or 24 milligrams twice a day, which both will provide similar efficacy and tolerability for most patients. And the only problem I think in some of patients is the gastritis, so therefore it has to be taken after meals. And of course, there's a safety concern for patients who have asthma. But high-dose beta-histine at 48 milligrams 3 times a day has even become shown to be more effective, especially in the long-term control of vertigo. There's also some evidence that it has some prophylactic benefit for patients with Meniere's disease, so that if you decrease the number of attacks of vertigo, you're actually more likely to preserve the hearing structures of the patient. So in that respect, it might be important to give the several months duration of treatment for Meniere's disease. And normally I give it for at least 2 months, and then see whether the patient will be able to have vertigo-free interval of 2 months before I start reducing the dose. So here's a case of a 34-year-old woman who presented with autophony, oral fullness, and vertigo. And the history of present illness showed that it's been present for weeks to several years. There's a gradual onset. It does not go away when the patient lies down. There's no history of ear infections. It was very bothersome to the ear, and it was induced by the vertigo could be induced by loud sounds. So what was very surprising was that when we actually did a hearing test in this patient, we saw a conductive hearing loss, which when we did the tympanometry or we look at the movement of the tympanic membrane with the tympanometry, there was no evidence of middle ear disease, and yet there was a conductive hearing loss. So this is what you call inner ear conductive hearing loss. And what's happening here is that there may be some pressure in the inner ear that actually limits the movement of the ossicles, and therefore shows like a conductive deficit on hearing test. So ignoring her symptoms, what other conditions could cause an audiogram like this, like a conductive hearing loss? Well, you can talk about ossicular pathology, of course. You can talk about autosclerosis, but you also have to consider a third window lesion. And when we say third window lesion, we're actually saying that there could be some dehiscence or thinning of one of the semicircular canals that can actually work like a third window, in addition to the natural windows, which is the oval window and the round window. So how can we tell these conditions apart before surgery? Some have done surgery and the surgery has failed to improve the patient. We have to do CT scans, and that's what you call high resolution CT scan of the temporal bone. That's plain, non-contrast. And you have to do what you call vestibular evoked myogenic potential testing. There's been very important strides in the diagnosis of patients with vertigo. When I graduated from medical school, basically we only had a caloric test. But over time, over the past 30 years, we've seen the maturity of the vestibular evoked myogenic potential testing. There's been also ocular VEMP as well. CT scans have become more higher in resolution so that we are able to delineate lesions that we were not able to diagnose before. And an example of this is what you'll see here. Here's the patient's left temporal bone plane on the coronal plane. And if you look closely, this is the cochlea and that's the ossicle. And you were trying to look for the cause of the conductive loss, and you can see the ossicles are actually intact. And the eardrum is intact. And yet once you see here, you can see here an absence of the bony cap over the superior semicircular canal. And in subsequent views, you can see here that there's a cut off of that bone. So that renders the superior semicircular canal actually open to the middle cranial fossa. And therefore, pressure in the intracranial vault can actually be transmitted to the low pressure area of the semicircular canals. So if you want to be able to see that in more detail, you can request what you call the Poschel's view, which is an image acquired parallel to the plane of the superior semicircular canal, which may be able to capture the entire dehiscence of the canal in one or two slices. Here's an example of a Poschel's view. You can see here that this is the loop of the superior semicircular canal, and you can see the absence of bone over the superior semicircular canal. So that's a dehiscent superior semicircular canal. And if you ask the patient to undergo what you call cervical VEMP, VEMP is done by giving some auditory signal through headphones and asking the patient to contract the sternocleidomastoid muscles. And you give some acoustic signals that will basically contract the SEM. You compare the contraction of the muscles of the neck on the right compared to the left. So what you can see here is in the blue is the left ear, and you can see here that even if you're just giving around 50 decibels of acoustic stimulation, you can elicit the VEMP response. Whereas on the right side, which is in red, you see here that you're only able to evoke the response, the VEMP response at 90 decibels. But lower than that, you don't have a response. And the normal threshold for Filipinos that I've seen is about 80 to 85. So you can see here that if your threshold is around 50, that's really a very abnormal low threshold of your VEMP, which is suggestive of a dehiscent superior semicircular canal on the left side. So true enough, if you open up this patient, as you can see in the upper left corner, you'll see here the dehiscent superior semicircular canal. When you open up, look at the temporal bone superiorly from a middle cranial fossa approach. And you'll have to be able to plug that by using soft tissue, some bone pate, as well as fascia, in order to give a layer of protection, several layers of protection, so that the pressure from the brain will not be transmitted to the semicircular canal. And here's a Poschel's view of that particular patient, where you have the cookie bite deformity and the absence of the bone over the superior canal. So in those patients, I've been able to treat more than 150 cases of superior canal with betahistine and maintain them on that. And for about 15% of cases, you will have to do surgery in order to control the vertigo, as well as the brain fog and disequilibrium in this patient. So another very important disease entity, which is actually more common, is the benign paroxysmal positional vertigo, which is can be caused by either cupulolithiasis or canalithiasis. And here's Hal Schutneck, who was one of my mentors at Harvard, who actually described BPPV first in 1969. And he showed here the basophilic deposits sitting on the cupula of the posterior semicircular canal, such that when the patient lies down in that provoking position, there's going to be vertigo lasting several seconds, but not more than 1 minute. You have to, again, differentiate it from the other conditions that can cause positional vertigo, like migraine, Meniere's disease, stroke as well. But what's important really is the duration. The duration here is less than 1 minute. And it's the history is very clear-cut. Usually it's provoked by a certain head position compared to, for example, migraine, which will have aura, Meniere's that will have some form of tinnitus and fluctuating hearing loss, and stroke, of course, I mentioned before. So the diagnostic test of choice is, of course, do the Dix-Hallpike test, which will entail asking the patient to sit on the table, move the patient's head to the right, and for example, and then bring it down very briskly to a head hanging position, and then look for the classical nystagmus, eutropic nystagmus that I mentioned initially. But that nystagmus will only be there for a few seconds. And if you bring up the patient, there's going to be a change in direction. Vertigo, the nystagmus will go to the opposite direction for a few seconds. If the patient is elderly, don't do the Dix-Hallpike. Do the log roll or Lempert roll test. And if you want to treat the patient, you can do what you call the Epley's canal positioning maneuver, which is done for posterior canal BPPV. And what you can see here is you do the initial Dix-Hallpike, and then you move the patient's head towards the opposite side, basically about 180 degrees, and then prone, make the patient prone head, and then sit up the patient. And this Epley's maneuver is actually very effective in treating patients with posterior canal BPPV. On the other hand, another treatment is what you call, and diagnostic test is what you call the Simon's maneuver, where you ask the patient to sit on the edge of the bed, side lie the patient on one side, wait for about 20 seconds, and then move the patient like a cartwheel so that the head is prone to the other side, and wait for the nystagmus or vertigo to disappear and then you sit up the patient. That's what you call the Simon's maneuver for BPPV. So normally we'd prefer the Epley maneuver for posterior canal lithiasis, and we'll prefer the Simon's maneuver for cupulolithiasis. And how do you differentiate between canal lithiasis and cupulolithiasis? It's the duration of the vertigo. Usually if it's canal lithiasis, it's less than 1 minute. If it's 1 minute, more than 1 minute, then that means it's stuck to the cupula, and that's probably cupulolithiasis, and therefore the treatment of choice probably will be a Simon's maneuver. And it's been noted in one study that if the nystagmus toward the affected side in the second position of Simon's maneuver is quite predictive of a successful treatment. You also use the Epley maneuver in patients who have difficulties extending the neck, because you don't have to extend the neck when you do the Simon's maneuver. Now, there's been evidence that there is what you call the Simon's plus maneuver. This has been described by Stroop, Michael Stroop from Munich. And that means that aside from just doing the usual Simon maneuver where the head is lying down on the bed, you actually overextend it to around 60 degrees from the horizontal axis. And then you move the patient's head to the opposite side very quickly, and then before you sit up the patient again. That's what you call the Simon plus maneuver. And a study by Stroop had shown that if it will take 3 days before the BPPV will subside in Simon's maneuver, in the Simon's plus, it will take half the time. Of course, BPPV of the posterior canal is probably the most common, but it's not the only cause of BPPV. We have been able to also see what you call horizontal canal BPPV. And when you see horizontal canal BPPV, which is diagnosed by the fact that when you do, for example, the Lempert roll test and move the patient's head to the right, you see nystagmus beating towards the right. And when you move the patient's head to the left, you also see nystagmus. But so you know what the affected ear by the velocity of the nystagmus usually beats faster in the affected ear. And therefore, if you see what you call geotropic nystagmus, then you do the Guffioni maneuver. But instead of moving the patient, so you move the patient's head side lie on the right. If it's apogeotropic, meaning to say the nystagmus that you are able to elicit is moving towards the ceiling, then you move the patient's 45 degrees up. But if the nystagmus is actually towards the floor, then you move the patient's head towards the floor. So that's the Guffioni. So either you do it for a head up or head down with the Guffioni, and that depends on whether the horizontal BPPV is geotropic or apogeotropic. There's also a possibility for you to actually just tell the patient to just do it at home, and that's what we call the Brandt-Daroff exercise, which is also an alternative treatment for posterior canal BPPV. You can do this for well-motivated individuals who are not afraid to do it at home, or you can tell the bantay or the kasambahay to actually be with the patient when doing these Brandt-Daroff exercises. It's been shown to be effective as well. They have to do this for about 2 weeks, and if by doing it for 2 weeks there's no more a BPPV episode, then you know that the patient has been treated, and therefore you just advise this patient. But however, if in 2 weeks it's persistent, you ask the patient to come back to you for a re-evaluation. Is there a role for beta-histine for patients with BPPV? Yes, there's been studies, for example, from Cavalier in 2005, that beta-histine, in addition to the maneuver, either Lempert or Brandt-Daroff, can actually result in faster recovery and significant improvement in day 14 and 30. And also another study by Guderi and Kustuhan, where beta-histine combined with the Epley maneuver was actually more effective than Epley maneuver alone, using the vertigo symptom scale. Another disease, and perhaps the last that I'd like to discuss with you, is vestibular paroxysma, which is actually the presence of this loop of artery inside the internal auditory canal, or just at the meatal area, where the nerve complex, the 7th and the 8th nerve complex, will be going into the internal auditory canal. You can see here on the right bottom part of your screen is some where the arterial loop has been badgering on the nerve, and that's the one causing sometimes either hemifacial spasm, but in this case it's actually vestibular paroxysm or attacks of vertigo, which is in paroxysms or episodic. So there's been a diagnosis that's actually based on the number of attacks of the spinning or non-spinning vertigo. If the duration is less than 1 minute, if it's spontaneously occurring, and the stereotype phenomenology in a particular patient is present, and there's a response to treatment with the sodium channel blocker, then that's probably vestibular paroxysmia. But if there's only about 5 attacks and the duration is less than 5 minutes, with all the other conditions, then that's probably probable only vestibular paroxysmia. So the last part of my presentation is actually, can you actually treat patients with vertigo in the COVID-19 era? Yes. The virtual practice has made major leaps in the way we treat patients with vertigo also. But the key aim really is to be able to triage patients into those requiring urgent emergency room or inpatient assessment versus those who can be actually seen non-urgently. So you might, the goal would be to actually define properly the eye movement and to be able to do a vestibular examination using some platform. So you can use the phone to be able to document the presence of nystagmus. I asked them to do a hearing test using the MD Hearing app to look for hearing loss, and send to me the tracing by Viber. You may be able to design a pathway by which you are able to guide the patient. But the most important is you have to see the patient. So you want to prioritize those who you will see in the hospital or in the clinic versus those who might be treated at home. And having said that, I have been able to use a validated questionnaire for BPPV as it's been described by Lindell et al. And if you go through these 15 questions, you'll be able to know whether the patient actually has BPPV. And if so, there's actually a possibility to ask a patient to have a video of how they're able to self-administer either the modified Epley maneuver. That can also be done. So the patient's given instructions of how to do it by sending a video, and then they can just follow that, and then they can tell you what has happened. So I've been able to treat some of my patients with vertigo using the virtual platform and using these parameters. So the success rate for self-administered FPCRP or Simon's treatment or Simon's maneuver actually is quite good also. The success rate is about 95% with self-administration of the Epley's maneuver and about 58% with the Simon's maneuver. The only caveat here really is that if there's actually a possibility that one might convert a posterior canal BPPV to a horizontal canal BPPV. So that's the only danger according to Susan Herdman and co-workers. But having said that, if it does convert, there's a treatment for horizontal canal BPPV that can also, of course, be done at home. And that's what you call the self-administered Vanucci's force prolonged position as a home-based treatment for horizontal canal BPPV. So you ask the patient to lie with the unaffected ear down for approximately 12 hours. And then this should be able to already treat the horizontal canal BPPV. But if you're not sure, I just tell the patient, well, just do just lie down on the unaffected ear and then let's see what happens. If it doesn't go away, then you can do it on the other side. And then if it still doesn't go away, then it's time to see me. So with that, I'd like to thank you all for listening. I'd like to again acknowledge the organizers for the 22nd version of the Grand Scientific Symposium. I'd like to thank the Postgraduate Institute of Medicine headed by our moderator, Dr. Tech Gloria Cruz. And of course, I'd like to thank our sponsor, which I think is actually the Diamond sponsor, Abbott, for this unrestricted educational grant. Maraming salamat po.
Thank you very much, Dean Charlotte, for that very informative, extensive, and relevant lecture on vertigo, which I'm sure many healthcare professionals encounter, whether professionally or personally. Now, we have had 1,275 attendees.
Wow.
And ma'am, the first question is very relevant for our attendees. What foods should a person with vertigo avoid?
Yeah, I've been very clear about instructions regarding salt intake, especially for patients with vertigo, and especially of the Meniere's disease variety, because we do know that's what you call this Chinese restaurant syndrome, where after taking a lot of salt or monosodium glutamate, the patient can actually have a triggered attack of vertigo because of the diet. So having said that, I think that's the most important. Now for caffeine, I also have had patients who have had severe fluctuating hearing loss or fullness that when I took out the caffeine from their diet also improved quite well. And I remember a particular case who has been suffering from very intermittent tinnitus, and I found out that this particular patient was actually taking 10 cups of coffee a day. So I had to limit him to one and make sure that if it's really important for them to drink tea, for example, then I tell them to get the decaffeinated variety.
Thank you, ma'am. So salt and coffee.
Yes.
Buti na lang, ma'am, sugar ang nilalagay sa coffee. Hindi, pareho na talagang hindi pwede. Ma'am, another question is, what's the difference between sinarizine and beta-histine?
Well, sinarizine is actually sort of like a calcium channel blocker also. No, it's like I think the main function is to improve the blood supply. So the advantage of beta-histine is that it doesn't only improve the blood supply, but it also has central effects, no? Because the peripheral effect is actually on the blood vessel diameter. So you cause vasodilatation because of the H1 agonist properties, but actually with the H3 antagonism in the brain, you're able to modulate the responses in the central vestibular nuclei. So in that respect, I think beta-histine has more advantages over sinarizine. However, having said that, sinaricin is also more sedating than betahistine. And therefore, if a patient has some difficulty in sleeping, I sometimes, especially in the elderly individuals, sometimes I'd add on sinaricin at bedtime, but not usually during the day, usually at bedtime.
Thank you, ma'am. Are there any more questions? Oh, here, ma'am, can betahistine be given to pregnant patients? And also, how long can you give betahistine?
I think there's a warning that you cannot give betahistine actually for the first trimester of pregnancy. But generally, as other drugs, you may be able to give it already at the third trimester or even the second trimester. How long can you give it? If you look at the literature, there have been reports where betahistine is actually given for years, no? And it's just a matter of what is the actual dose that the patient will need. My minimum is actually, for example, for BPPV is about 10 days to maximum of 2 weeks. But if I'm going to use it for Meniere's disease, where I know that the homeostasis of the inner ear will take a longer period of time, I normally give it for at least 2 months. And that's something that I lay out to the patient already. I tell them that if I'm going to give this to you only a prescription of about 1 or 2 weeks, you might think that it's enough, but it's not. So I have to be able to tell you that for us to be able to stabilize the inner ear homeostasis, we may have to give you betahistine for at least 2 months. And if you come back and you keep a busy diary, you put a smiley face there and I can count how many smiley faces you have in those 2 months. And if I see that there's all smiling faces and no frowning, then we can start tapering off your betahistine.
Thank you very much, ma'am. That's a very useful practical advice.
Yeah.
Probably, ma'am, the last question, which is also very important. What are the symptoms of a patient with dizziness or vertigo that would make you send the patient at once to the ER?
Yes, usually vertigo of peripheral origin, the patient can walk. So if the patient cannot walk, I think that patient has to go to the ER. That's one, because you need to be able to evaluate that patient. Normally, those causes of vertigo that will actually cause a lot of ataxia, probably you really have to rule out central pathology. Having said that, I already told you about what the basic things that you have to do in the ER, and that's you perform the hints. That means head impulse, test for nystagmus, and look for skew deviation. If you see that there's skew deviation and it's a negative head impulse test, then that patient has to go for a diffusion-weighted imaging MRI, because you might be able to see just a very small infarct and you'd like to be able to intervene before it becomes more serious. And I've seen that in the ate of my best friend. She's been having vertigo. She's gone to 2 internal medicine specialists. Her medications for cardiac were actually changed, but the only thing that I got in the history is that when she went to SM, she had to grab onto the hand of the husband because she cannot walk anymore. So I told my friend, I better see your ate. So when I saw her, it was clear to me that there was some skew deviation that I had, that I thought we needed an MRI, and she was in my VC at that time. So I had to call medical city, I had to call where the MRI could be done, and finally she ended up in Manila Doctors Hospital, and lo and behold, we saw a medullary infarct of about 2 millimeters.
Yes, ma'am. So stroke. So
Yes.
in this day of COVID-19 kasi, ma'am, syempre as much as possible, ayaw sanang pumunta sa ospital. Pero gaya po ng sinabi nyo, pag ang hilo ay may kasama ng unsteadiness or ataxia, and then maybe persistent headache, uncontrolled BP at home, dalhin na sa ospital.
Yes,
So,
hindi na makakaya.
Opo. Maraming salamat, ma'am. I think wala na pong mga tanong sa Q&A box natin. Mas may comments na po ng congratulations. So, thank you everybody for staying, and thank you very much again to our generous sponsor for this Twilight Symposium on Vertigo. Thank you, Dr. Chong.
Thank you very much, and have a safe evening, and see you tomorrow.
Oh, so for our, may I then call on our brand manager from our reliable and dependable partner in healthcare, Abbott. May I call on Ma'am Nina Diego, please?
Thank you so much. Maayong gabi sa inyong lahat. Good evening to everyone. Ako po si Nina Diego, yung brand manager po ng CERC and CNS. And to the UP College of Medicine and UP Medical Alumni Society, in behalf of our company, Abbott Laboratories, we would like to congratulate your alumni for a successful day one of your 75th anniversary celebration. And to the UPMAS Davao chapter headed by Dr. Christine Del Monte Dayangkirang and Dr. Cecil Serrano, and the rest of the UPMAS Davao chapter organizing committee, we commend the great leadership that has brought the success of this event so far. So once again, we'd like to thank our speaker, your very own Dean College of Medicine, Dr. Charlotte Chong, for the very informative, practical, and superb lecture on vertigo, and to our excellent moderator, Dr. Teresa Luisa Cruz. Maraming salamat po. So Abbott would like to extend our appreciation for giving us this opportunity to be part of your continuing medical education. May we remain partners in your future scientific activities. So with that, thank you everyone and have a pleasant and safe evening to all.
Thank you very much, Ma'am Nina.
Thank you.
And again, thank you. Back to you, Twinkle. Twinkle, back to you.
Thank you, Doc. We would like to present the certificate of appreciation to Dr. Jubert Benedicto for his invaluable contribution as a resource speaker on COVID-19 antiviral and ancillary treatment. Thank you. Thank you, Dr. Chong. Thank you also to the participants for joining us today. Your attendance is greatly appreciated. We would like to ask all our attendees to answer the evaluation form as part of your attendance. CPD units will be credited from your attendance. Please use this QR code or find the link on the chat box below. As day one of our Grand Scientific Symposium comes to a close, we invite everyone to attend the conference tomorrow. We still have another batch of exciting topics to discuss, along with a esteemed lineup of our upcoming speakers. Good evening, everyone, and see you all tomorrow.